Live.
Hello, good evening, everyone. And it's with a great pleasure that we welcome you all for the day two. And this is, we bring you ONCOV 2026 on the day two clinical updates from the recent international conferences. Yesterday, we had a great discussion. And today also, we have a lot of important topics which are lined up. Without wasting any much time, it's a great pleasure to welcome and invite Dr. Mukesh Bansal. Sir, good evening to you, and thank you so much for convening this meeting. And I request you for your welcome note and start the proceedings of the day, please. Over to you, Dr. Mukesh, sir.
Yeah, thank you, Mathurji, for the nice startup. So, good evening, everyone. I welcome you all in the second day of ONCOV 2026, the third edition of clinical updates from recent international conferences. Yesterday, we had a very fruitful day. We had a great discussions, and I hope the trend will continue today also. And I will again request all the speakers and moderators to adhere to the time limits so that we can finish timely. For the first session of the day, I welcome Dr. Kanika Sharma, Consultant Medical Oncologist, Sohana Super Specialty Hospital, Mohali. Dr. Kanika will be speaking on ADCs in breast cancer, the new horizons. Welcome and over to you, Dr. Kanika.
Thank you, Dr. Mukesh. Thank you for the kind invitation. So are my slides visible?
Yes, they are visible now. You can make it in the presentation mode. Yes.
So yes, we'll be talking about the ADCs. So as we know now, I think this decade is towards the targeted therapies, the drug conjugates, and the CAR-T that we are talking about. So when we talk about the ADCs, they are the antibody drug conjugate that delivers the cytotoxic drug directly to the cell via linker that is attached to a monoclonal antibodies. So basically, they bind to a receptor on the surface of these cells. They localize the tumor based on that target receptor. So the receptor antigen and the ADCs, then they are internalized by the endocytosis. There's enzymatically degraded with lysosome. So drug is specifically released intracellularly, and they act via that, leading to death of the tumor cells. And they also have a bystander effect also, leading to an effective outcomes. So there is a payload mechanism of action that we use, whether it's a topoisomerase inhibitor or the other mechanism. What is the drug to antibody ratio that differ as we see in the TDM1 versus TDXT? What is the tumor selective cleavable linkage so that it easily delivers the drug to the target? And again, the bystander, as I was talking. So when we talk about the timeline of ADCs in breast cancer, it started with the TDM1 in 2013. And then we have various indication. It was approved from the metastatic to now in the adjuvant setting as well. Then came the TDXT, again the pre-treatment. And now we know that we have a plenty of approval for TDXD in almost all the indication in breast cancer nowadays. Then we have a sacituzumab govitecan molecule. So all these molecules were tried in the metastatic settings, and based on the effectiveness and the side effect profile of these molecules, they were taken ahead in their line. And then we have dato-DXd, which very soon we'll be able to use. Now they are available in trials. So when we talk about the key differences between all these molecules, whether it's a dato-DXd or TDXd or a sacituzumab govitecan, so the issue is the target. So both dato and SG, they act on the TROP2 mechanism, whereas the TDXD is a HER2 targetable. Then the other is the payload. All of them are topoisomerase 1 inhibitor that is used. And then there is a drug antibody ratio that is there with the highest within HER2, and followed by SG and then dato-DXd. So all of these, they demonstrate bystander effect in the clinical practice, and these ADCs, they bind to the antigen within the tumor and then subsequent internalization causing the surrounding effects. So when we talk about the TROP2 as a target, it's a candidate target for the cancer treatment. It's basically a transmembrane glycoprotein that is expressed in the epithelial tissues, and they promote cell proliferation, survival, and invasion. So high TROP2 expression, it is associated with disease progression. So it's a both ways. So because of high TROP2, there are disease progression. So it specifically targets and leads to an effective treatment in these patients. So coming to a phase 3, that is a TROPIC-02 that evaluated SG in patients with metastatic or locally recurrent inoperable diseases. And we can see the separation of graph between the two, that is the physician choice of drug versus SG. That is the 5.5 versus 4 months. And when we talk about the OS also, there is a 3 months benefit with the SG as compared to the chemotherapy. Again, when we talk about the HER2 low and HER2 zero, now it has become mandatory with these all those molecules to check the HER2 low status as well. And there was a similar overall survival results whether the patient have HER2 low. So it's irrespective because of the TROP2 targeted approach. Then coming the tropion data, that is of dato-DXd. So when we see the primary outcome of these molecules, so there is a 2 months benefit with dato-DXd. And when we talk about the overall survival also, it's 18.6 versus 18.2, though the graphs are almost overlapping. But we can see at 12 months also, there is a benefit in the PFS. So we'll be needing a more data for these. So when we talk about the tropion breast, the side effect profile, so the most common with these are the oral mucositis, stomatitis, the ocular event, and the ILD. So with all these drugs, so the rates are low, mainly grade 1 and 2, but these need to be monitored in these patients. So again, for the toxicity management, the mucositis and stomatitis, with dato-DXd, so a daily prophylaxis of a steroid-containing mouthwash, it is highly recommended. And prophylactic cryotherapy, so patient can be advised to use ice chips or ice water through the infusion that we also advised during our chemotherapy also that causes acute mucositis. So that are helpful. And for the ocular, again, an artificial tear and avoidance of contact lens should be recommended for these patients. So now how to sequence the ADC in clinical practice? So when we talk about the hormone positive metastatic breast cancer, again, the primary treatment is still ER directed treatments that are quite effective. But when we are exhausted after 2 and 3 lines of therapy, and if the patient have a high burden disease, visceral mets, then TDXD, that is the DB06 data is there now. Even in the earlier line also it is approved. And then we can base, since both of them are TROP2 directed, whether dato-DXd versus SG or vice versa, based on the patient preference and the treatment profile that can be selected. So there is some degree of cross resistance between these topo 1 ADCs. So again, obviously with the same mechanism, it is not advisable to use both the molecules, but one over the other can be selected based on that. So when we talk about the HER2 low MBC, the first ADC use may have a greatest benefit regardless of the HR status and the ADC use. So that is definitely see when we see use the SG first followed by TDXG or vice versa. Because the tumor cells are naive to these ADCs and the topoisomerase 1 inhibitor, so the first drug may have a higher advantage. So any of these drugs based on the experience can be used in these patients. So in the 90% low or ultra low MBCs, again after endocrine therapy, the preferred is because there are more data TDXT. Then in the subsequent line, dato-DXd and sacituximab can be weighed. So again, it is always the preferred ADC. Now we have so much data and so many different lines of therapy. And even a sandwich strategy with chemotherapy in between ADCs can be used, like if the patient have progressed, to give interim chemotherapy and then again re-challenge with an ADC for these patients. They also have a better brain penetrance also. So when we talk about the TNBC, which we know is a very highly aggressive subset, so there are various unmet needs that we have in these patients. So again, we have a very few options. The chemotherapy is the primary treatment. Again, the 70% of the patients, they are not candidate for the immunotherapy because of the low or the negative PD-L1 status and the cost. So, and many of them, they do not receive a treatment beyond first line also. So we need to assess these patients. This was an ASCENT trial that have determined the benefit of SG in a previously treated TNBC patients. So they have taken metastatic TNBC patients who have received more than 2 lines of chemotherapy in the advanced setting. And again, they were stratified to SG, that is 10 mg per kg IV, day 1, day 8, every 3 weekly versus the physician choice of drug. And we can see that there is a PFS benefit of around 4 months of SG versus physician choice, because the chemo is also in the third line, so we don't have that many options also. And when we talk about the OS also, with a hazard ratio of 0.48, so there is almost a doubling of OS with SG in more than second line of options. Then it is an Opti-Trop breast 01, that is the SAC TMT in the pre-treated TNBC's patients. So the 5 mg per kg IV every 2 weekly versus the chemotherapy arm. And we can see that the overall objective response rate is around 45.4% as compared to only 12% with the chemotherapy, with a significant separation of graph that we can see in these patients. That is 6.7 versus 2.5 months. So these molecules, they do have benefits, especially after exhaustion of chemotherapy in the 1 and 2 lines of the treatment. So again, the pan-tumor tropion trial, that is the efficacy of dato-DXd in TNBC patients. We can see from this forest plot also, the objective response rate is significantly good in these patients. And when they are topoisomerase 1 naive patients, there is a benefit of around 3 months that is seen with the dato-DXd in these patients. So this was the ASCENT 03, that is the first line SG versus chemotherapy in the TNBC patients. So we have already seen that the patients, so it is irrespective PD-L1 negative or the PD-L1 positive, they have taken both the groups who are not candidate for PD-L1 inhibitors. So though the graphs are not separating as much, but we can see that the 6 months PFS, the overall around, we can say 3 months benefit is there in the patients who are TNBC with the SG. They have a similar objective response, but longer duration of response was observed when giving these ADCs as compared to the chemotherapy. So when we talk about the safety profile of these, so the all treatment related deaths with SG were due to the infections, and the 5 infections were secondary to neutropenia. So again, a good prophylactic GCSF support should be given to these patients on GC, because the neutropenia rate is quite high with these molecules, followed by leukopenia, nausea, diarrhea, and all these side effects that we see. So when we talk about the tropion breast 02, that is the dato-DXd in the first line metastatic TNBC. So it's a phase 3 trial, and it's an open label, that is the dato-DXd versus the chemotherapy as first line therapy for patients with locally recurrent, inoperable, or metastatic TNBC who are not candidate for immunotherapy, who have not received any prior chemotherapy or targeted systemic therapy. So they have taken dato-DXd 6 mg per kg every 3 weekly versus investigator choice of chemotherapy. So the baseline characteristics were comparable between the both arms. And when we see the progression-free survival, there is almost doubling of response that is seen till 18 months of the treatment. And the hazard ratio is 0.57 that is seen. So a delta of 5.3 months when we use these earlier. So if the cost constraints are not there, so these molecules, when used earlier, they have a significant response as compared to exhausting all the lines of the chemotherapy and then using them in the third and fourth line of settings. So when we talk about the overall survival also, there's a statistically significant improvement in OS with a risk reduction of around by 21%. So we can see this forest plot also, all the subgroup, they favored with the addition of dato-DXd as compared to the chemotherapy, whether it's the age, advanced age, the performance status, even the PD-L1 low patients, brain mets patient, and liver mets, that is the visceral disease also. So in the overall survival also, there is a benefit across all the subgroup favoring dato-DXd. So even with the objective response rate, there's a delta of 33.2% that is seen with the ADCs as compared to chemotherapy. So they have confirmed more than double as compared to chemotherapy. And the duration of response also, there is a doubling of response that is seen with the addition of these molecules. Safety profile, again, when we talk about the dose interruptions or the dose reduction, that is slightly higher as compared to chemotherapy. But despite the double, the rates of more than grade 3 and a serious treatment-related adverse effects were similar, and the discontinuation rates, they are almost similar and slightly lower with dato-DXd as compared to chemotherapy. So these are the same only. And again, the treatment-related adverse event, it's same like SG, oral mucositis, stomatitis, ocular, and the ILD. So these are the three main that need to be considered with both SG as well as dato-DXd. So summarizing this talk, it's a phase 3 TROP2 directed ADCs that have met both dual primary endpoint of OS and PFS, more than 5 months improvement in both OS and PFS, and a manageable side effect profile. Now, this is a combination of ADCs with IO, that is a ASCENT keynote combination study of the first line SG plus pembro versus chemotherapy in the PD-L1 positive patients. So we can see the combination of these therapy have shown a benefit in the PFS. The OS, again, subsequent 81% who received any subsequent treatment after discontinuation, they have received SJ in the subsequent line. So the OS is not that relevant in these patients, but the duration of response and the PFS is benefit. They have also assessed dato-DXd combination with durvalumab as well. And from this forest plot only, we can see that there's a significant benefit of adding both the two in the patients who have PD-L1 positive patients. So coming to the OptiTrop, that is the PFS benefit regardless of the PD-L1 expression that was seen with the sac-TMT. And the safety profile, again, the GCSF prophylaxis need to be given to these patients, and the CBC monitoring is very important when giving all these ADCs. So there are multiple ongoing investigations, you know, in the HER2 low settings, in the HR positive or HR low and TNBC, and moving these molecules forward. So we need to see many factors when deciding these ADCs. What is the dosing schedule, the sequencing, what to use first, when to, you know, sandwich in between the chemotherapy. So all these factors need to be taken into account. And again, there are a variety of factors also that determine the toxicity profile and the comorbidity that we need to see in these patients. So based on that, there are multiple ADCs that they are coming up across the metastatic MBC, and the gradually PFS and OS, they are improving with all these molecules coming up. So thank you so much for your patient listening.
Thank you, Dr. Kanika, for the comprehensive presentation. Any experience of yours in using these ADCs in breast cancer, especially in HER2 low setting or TNBC?
So in HER2, now I have a fair number of patients that I have used in these patients.
Okay.
But even the dato-DXd I've used in one patient that previously at Max we were there, trial, Tropion trial was undergoing, and we have enrolled one patient. So the stomatitis and this oral mucositis, that is a major challenge with this drug. That was, but the response rates and the tolerance was good with that molecule also.
And any toxicity you faced with N-HER2, or you will
And HER2, again, ILD need to be monitored. But the nausea, vomiting, and the neutropenias, that is fairly well managed with, I think, GCSF support and good anti-emetics actually.
Thank you. Thank you so much. So now moving on to the next session, which is low dose immunotherapy in head and neck cancer, which I think is very much relevant in resource constrained settings like our country. And for this, I will like to welcome Dr. Jatin Sreen sir. Sir needs no introduction. Sir is Director Medical Oncology at Livasa Hospital, Mohali. Thank you so much, sir, for joining. Over to you, sir.
Thank you, Mukesh, for giving me just this responsibility. And I full support to this meeting. And they are wonderful session. I was able to hear only the Kanika's session. It was a very comprehensive presentation. So, can someone invite my panelists for me, and also can someone share the slides?
Yeah, I can invite the panelists, sir, if you say.
Uh,
Dr. Gautam Goyal, sir, Director Medical Oncology, Sohana Super Specialty Hospital, Mohali. Dr. Chandrasekhar Prasad Singh, Senior Consultant Medical Oncologist, HCG Abdul Razak Cancer Center, Ranchi. Dr. Deepak Uppal, Consultant Medical Oncologist, Amar Hospital, Patiala. Dr. Movin Mittal, Consultant Medical Oncologist at Park Hospital, Patiala and Ambala. Dr. Deepak Singla, Senior Consultant Medical Oncologist, Indus Super Specialty Hospital, Mohali. Dr. Ved Manasa, Consultant Radiation Oncologist at Ojas Hospital, Panchkula.
okay. So, yeah. So I think, good evening, everyone, and welcome all panelists. I think this is all very close to our heart, especially working in a tier two city. Uh, uh, and this is the most relevant question asked right at the start of panel, that is this panel discussion actually needed? Yes, we all know that the problem is very real. In US, 50% of all Americans carry medical debt. 50% of all women with metastasis are being pursued by debt collectors. And 42% of newly diagnosed cancer patients go bankrupt within 2 to 3 years of diagnosis. Hopefully, the scenario is not that bad in India, despite being a low per capita country. Next slide. So the first and foremost question to all my panelists, each of them can respond. How many of your patients can afford full dose or maybe low dose of immune checkpoint inhibitors in their day-to-day practice? Starting with Gautam.
Hello, sir. Sir, if we take full dose immune checkpoint inhibitors, near about 30% of my patients are able to, 30 to 35% are able to afford the treatment. And if we go for modified, that is low dose, yes, 55 to 60% of patients can afford immune checkpoint inhibitors. Still, 30 to 40% are not able to afford even after low dose therapies because of the continuation of the therapy for the long time.
Okay. Next. Do I
Hi,
have
sir. Good evening.
good evening?
I practice in Ranchi. It is a tier 2 city. So, I would say less than 10% of my patients do have access to full dose immunotherapy. Now, fortunately, we have immune checkpoint inhibitors in government schemes like nivolumab. We can give Tistha, which is available. We can give tislelizumab. So these are the options we have, and more patients are getting that benefit through government schemes. So as of now, I think one third of patients can have access to immune checkpoint inhibitors. Yes.
So have you tried low dose immunotherapy?
Yes, sir. Majority of my patients are on low dose immunotherapy only, sir.
Okay. And taking both those full dose and low dose into account, 30 to 35% of your patients are able to have access to these drugs.
Yes, sir. Yes, sir.
Okay. And where in Patna you are working?
I'm
Which,
working in Ranchi, sir, Jharkhand.
sorry,
So
Ranchi.
now they have included in their government schemes. They have named different. Ayushman
Is
is
it,
Ayushman scheme, but they have modified it state government. So now
is
they
it,
are giving
is it a
coverage up
government
to
sector?
15 lakh.
Is it a public hospital or a private
It is a
hospital?
private center, sir, HCG.
HCG.
Yes.
Okay, fine. Thank you. Next. Uh, who's the other panelist I'm
Yes,
having?
sir.
Yes, sir.
Sir, Sir Dr. Mubin from Park Hospital. Uh,
Yeah,
Sir,
yeah, move in.
in my day-to-day practice, approximately 10 to 15% patients able to afford full dose immunotherapy. And apart from the government schemes, if we reduce the dose, low dose therapy can be tolerated by the 30 to 40% of patients can afford low dose therapy.
Fine, fine, fine. Next, who's there? Deepak?
Yes, sir. Yes, sir. Sir, I agree with the 50 to 20% patient afford full dose chemo immunotherapy.
Mhm.
And with the low dose, that number may rise to 30%, but as of now, not more than that, sir.
Okay, okay. So anyone left out? So, going by each of yours feedback, even in my case, I would say low dose, yes, around 30, 35, or at the max 40%, I would say. And full dose, only 10 to 15%, the ones who can afford immunotherapy. Uh,
Dr. Sajjan, one question I
yes,
have.
sir.
You are using standard low dose chemotherapy or any chemotherapy, one-fourth dose immunotherapy, one-fourth dose low dose chemotherapy. I mean, that is what I'm trying to ask. Any drug, one-fourth dose becomes a low dose or standard, which have been proven in trials.
Okay. So, the only low dose I have used is nivolumab, and that is available in 40 mg vials. So we are using 40 mg monthly, every 28 days. We don't have the luxury of so many patients, so I can't divide the dose 20 mg in two patients, and that is to be given every 15 days. So we are using 40 mg most of the time, monthly. No other immunotherapy I am able to as such use low dose. If someone has used Durva low dose 500 mg or 50 mg, we can discuss that. So next slide. So the access to ICI, and this is a real world data of ICI in solid tumors from India, and you can see in 2021 it was this is from one of the largest center, that is TMH Mumbai. In 2021, they say only 1.61% of cases were able to take or had access to ICI, and that number increased by just 1% more in the subsequent year. So I think this is what encouraged them to conduct the trials of since these are wonderful drugs, and sometimes we have seen unprecedented results, especially in combination with chemotherapy. Deepak, okay. Mm. Uh, uh, so Deepak, you were left out. I didn't ask you. You're busy with something. So
No,
how
no, no. I am very much there, sir.
you're there? Okay. So in your practice, how many can easily afford full dose immunotherapy, and how many can take low dose immunotherapy in your practice?
So majority of my patients are impaneled patient, more than 80% of them. And majority of them, if indicated, they do tolerate immunotherapy very well. I mean, okay. And there is not much tolerability issues with that. But if I talking about the paying patient, hardly less than 10% patient they can afford a full dose of immunotherapy. If we use low dose, yes, it can be 20-25%.
20-25%.
Hardly.
So with the advent of the generics, say Tishtha, do you think the access to IOs have increased drastically?
Yes, sir. I mean, it was the need of hour, and I believe that people, now starting considering about immunotherapy. When we tell them that now generics are also available, we can substitute not only in head and neck, in other other malignancies as well. So people, they do tend to consider when we tell them the cost is 30-40,000 and as compared to 2 lakh. So I mean, they do consider.
And so many other ICIs, especially the Chinese brand like Serplulimab or Toripalimab or for that matter.
Yes, sir. Definitely, just like other, when we 10 years back, when we used to use only Mapthra rituximab, once the generic came, it become affordable to, and majority of the more than 70% patient can affordable, so I think the time will come when the number will increase as.
So next slide, yes. So why low dose? Why people thought about low dose? So there are three things. There was a scientific rationale, and then on the basis of that rationale, clinical studies were conducted. And after that, there were some real world studies. Next slide. We all know this whole cartoon, how the CTLA4 and PD-1 inhibitors work. I won't go into the detail at this point of time. Next slide. So what are the inferences of pharmacokinetic and pharmacodynamic and dose finding studies? Next slide. So the key metric of response in anti-PD-1 antibodies is cytokine IL-2 production by the T cells. If there is an increase in IL-2 production, you have a response to immunotherapy, and it was seen that IL-2 production was not seen in the increase in IL-2 production was not seen after 0.3 milligram per kg in animal models, and the 95% of target engagement with a single dose of 1 mg per kg was seen. So, and another thing, there was no significant difference in the tumor response at doses ranging from 1 to 10 mg per kg every 3 weeks. Next slide. Same with nivolumab. Flat exposure response relationship with doses of 1 mg per kg as varied as 1 mg per kg to 10 mg per kg biweekly. And a trough concentration of 16 microgram per DL for 3 mg per kg is actually 160 times which is required for max receptor bridging, as 0.04 microgram per DL is enough to occupy more than 70% of PDL1 receptors. So peripheral receptor occupancy was saturated at doses more than equal to 0.3 mg per kg. So, and there were few studies for efficacy in melanoma and RCC. And personally, I also have some experience of using a low dose nivolumab in both melanoma and RCC at a time when there was some affordability access issues with the patient, and it was efficacious actually. So any such experience, I mean, we have nivolumab since long. So any such experience of all my panelists out here of using low dose immuno in RCC or say melanoma, because I vividly remember at those times, there was not much of schemes also were there, and full dose people used to get exhausted as far as their finances were concerned. So, but I think the concept of low dose came just because of the as Deepak said, it was a need of the hour. So, anyone who had used low dose immuno in melanoma or RCC, which are actually the tumors in which you have not many other agents available. Gautam?
Sir, I think in melanoma, I have used in one patient.
Mm-hmm.
RCC, I have not used in any of the patients. Low
Okay.
dose.
And the one in whom you used in melanoma, how did you find the response and results?
Sir, melanoma which I have used, that was a vaginal melanoma. These are usually bad melanomas to treat, mucosal melanomas.
Oh,
So
yeah.
there was no response. I understand we can't label it at the low dose or the high dose.
No,
Oh,
so it
yes,
is mainly the cutaneous who actually respond well,
it is
because
yes, yes,
mucosal melanomas or amelanotics are not the good ones. So
yes.
anyway, anyone else who's having an experience? Anyone who can share their experience? So this is a very informal talk. Basically, we are going to discuss that is this low dose usage of low dose immunotherapy is actually guilt free or not. So anyone
Yes,
interested?
sir. I think majority of my RCC
Yeah,
patients are on low dose Nivo Cabo only here. Majority are government scheme patients, and they are on low dose Nivo plus Cabo. So I get good responses. Uh, but
yeah,
yes, I would say the responses are not that durable, I would say, as compared to full dose. But yes, initially we do get response.
durable. You feel there is a lack of
Yes,
durable.
particularly in RCC where I have patients on full dose Nivocabo,
Mm.
and I have patients on low dose Nivocabo. I would say the responses
So
are
the
not that
concern
durable.
raised is durability of response. Yes, someone was there in the in between. Uh, uh, Someone spoke in between also.
Dr. Nitin, Alok here.
Alok, yeah, Alok.
So I have used it in few patients. So I will say the sample size is too small to say whether, because we have seen patients on high dose immunotherapy, full dose immunotherapy also failing. So
Yeah,
we don't have a perfect marker, and we have seen patient in melanoma, mucosal melanoma
difficult to
especially,
compare. Yeah.
and RCC who are failing on full dose immunotherapy also. So I
Mm.
have patients. So I feel they are doing fairly well. So it is better to give something rather than not giving anything. They definitely benefit.
Mm.
Durability, I think I don't have a sample size to say that patient respond differently. To say that okay, it is due to
Yeah.
low dose or it is due to some pharmacokinetics, it's difficult to say.
So each of us have must be having a very, very minuscule experience or whatever. Some people would be having a good number of patients. And I think the data needs to be developed, and they are being studied in institute like yours, I think, Alok, and also in PGI and probably in other government institutions also. So yes, next slide, please. So immunotherapy is intriguing. There's nothing to say on this. Next slide, please. So, A 64-year-old male resident of UP with no comorbidities, metastatic RCC, clear cell with lymph node metastasis and IMDC intermediate risk, low HB. So he was treated with 40 mg biweekly and or 80 mg 4 weeks along with cabozantinib. Next slide, please. So these are the actual patients who are being treated, and he responded. Now he responded because of immuno or because of an effective drug, otherwise also cabozantinib. So we don't know, but again, the cost constraints allowed only two doses of nivolumab to be given. And after that, he was on cabozantinib and responding. So such things also people practice. Next slide, please. So there were prospective studies. Next slide. So this was a article in JCO that survival, durable tumor remission, and long-term safety in patient with advanced melanoma receiving nivolumab. And if you see in all doses, the response rates were overall response rates were around 30.8%. And even if you increase the doses, the response rate, overall response rate hardly tend to vary. And in fact, they were better with lower dose, that is 0.3 mg per kg. You see, you have, or 0.1 mg per kg, there is a response of around 35.3%. So, and if you see the stable disease at more than equal to 24 weeks, the lower dose, that is 1 mg per kg, is having a maximum percentage of stable disease more than equal to 24 weeks, and so was the PFS benefit and other things. So in this, if you can see, the higher dosage actually fared worse than the lower dosage, and the optimal dose, difficult to say. Yes, but I think 1 mg per kg is a good enough dosage for melanoma. And the statement written here is that among 11 patients who experienced disease progression following treatment with nivolumab at 0.1 or 0.3 mg per kg, none responded following dose escalation to 1 mg per kg. Next slide, please. So this was in RCC. RCC also, it was seen that time to response and ongoing treatment response with the lowest dose, that is 0.3 mg per kg. You can see the bar, and you can see the bars with 2 mg per kg. So hardly much of a difference if you use higher dose, and again a reason for using a low dose immunotherapy. Next slide, please. So in Durva also, you have a pharmacokinetic model prediction that it was seen that 10 mg per kg and 1500 milligram per kg Q4 weekly nearly equivalent, because if you calculate the dose with 10 mg per kg, again the doses are quite low as compared to the flat dose of 1500 mg per kg. Next slide. There was this study. This is just one of the case, but there was some there was a study also in a small pilot study by one of our colleagues of low dose durvalumab in gallbladder cancer, and this was just a gallbladder cancer small cell variants. And he had T3N2 disease, and there was presence of retroperitoneal and intrahepatic lymph nodes. But post-op imaging showed it was there was peripancreatic lymph node also positive. Next slide, please. Next slide. So he was given cisplatin etoposide with 500 milligram of durvalumab, and I think he started treatment in May 23, and it is he is in remission till 25. Next slide.
Sir, sorry for intervening. Need to conclude, please.
So yes, I think for most of the IOs, I think a low dose option is a viable option, and now there are standardized studies which are going on the basis of these pharmacokinetics and pharmacodynamic parameters, and it is here to stay, and it will be a boon to countries like ours, in which the access to the treatment is limited. If anyone has anything else to say, please, one can make a comment.
Dr. Jatin, one thing I want to mention here. This nivolumab, I read somewhere that it can be stored for 4 weeks at -2 to -8. So if we want to use 20 mg, that can be used, the remaining vial can be used
Yes,
later.
this can be explored. This can be explored. Yes. True.
And in non-small cell lung cancer, there are studies.
So have you tried this?
No, I have not stored it because we are using 40 mg.
I haven't tried it in my practice, but yes, I agreed. You're totally. It can be stored for 4 weeks. So thank you, my panelists.
One last question, sir. Have you used low dose immunotherapy in concurrence with radiation, and has it changed the side effect profile in any way?
I haven't used immunotherapy with radiation, and neither full dose, neither low dose as such. If you have some experience, please go ahead.
No, sir. Even I was looking for answers here.
Answer is that in a curable cancer, please do not use other than recommended doses. For palliation, yes, you can use anywhere and everywhere these.
Yeah, I think if it is in a curative setting, as rightly said by sir, one should stick to the trial scenario only, and we should use standard doses. Maybe if, in radiation, I think in head and neck we have Nivo post-op trial and all those stuff.
Yes.
So for the people who are not having access to a full dose, I mean, I haven't had the experience to use it with you know, radiation as yet. Anyone else who has the experience, please go ahead. So if no one has anything else to say, thank you, Mukesh, once again for giving me the opportunity to have this wonderful chat with my colleagues. Thank you.
Thank you so much, sir. Thank you for the wonderful moderation. Thank you all the panelists for active participation. Thank you. So for the moving on to the next session, I will like to welcome Dr. Rajeshwar Singh, sir. Again, no introduction needed. Sir is Director Medical Oncology at Paras Health, Panchkula. Sir, can you welcome, and can you please invite the speaker?
Thank you, Mukesh. There was a lovely discussion which was need of hour for our patient. We have a lot of patients who are not affording. Now coming on to the next, it's a panel discussion, breakthrough abstract in ASCO ESMO 2026. Moderator is our friend Dr. Sachin Gupta from Max Mohali. I'll request Dr. Sachin to introduce his panelist also. Dr. Sachin, please.
Yeah, thank you, sir. And thank you, Mukesh, for organizing this webinar. So this panel discussion is about three very important trials, which could be practice changing, and very interesting trials are there. And I'll invite my panelists here. Let me just take out the names. So I hope everybody has joined. Dr. Chitresh, you're there? Dr. Chitresh, पहली wicket down होगी मेरी.
I think he's in the process of joining. Rest of
Okay,
them
Dr.
are there.
Alok Goyal. Dr. Alok was here. Dr. Alok, you're there? I just heard him sometime back.
Yeah, he was there only. I'm just need to check, sir. Just a second.
Okay, Dr. Nitika. Patrick हो गई है. Dr. Neha.
Just
अब मैं बाकी सबको पकड़ता हूँ जो यहाँ हैं. Dr. Ravinder is there, right?
Yes.
Can see him smiling. Yes, great. So Ravinder, you are going to handle everything now. Dr. Bhushan Parmar, he is also there, right?
Yes, sir. Good evening, sir.
And Dr. Munish Mahajan.
Yes, I'm there.
तो एक सर्जन फंस गया बीच में. हाँ? अभी डाटा बनाते थे.
सर्जन का कोई काम नहीं इसमें.
नहीं ऐसे we'll find something for you in this. Let's see. ठीक है. Okay, let me just share my screen. Okay. So, all right. ठीक है. I hope you can see these slides.
Yes.
Yeah. Okay, so I'm going to involve Dr. Ravinder, Dr. Bhushan, and Dr. Manish. If somebody else joins, please let me know.
Sir, you can involve Dr. Anuj. Sir is also here.
Dr. Jatin sir is also here, and
Dr. Anuj
Brigadier sir
Bansal
is also there,
here.
and Dr.
Anuj Bansal.
Dr. Anuj, I can see Deepak also, huh?
Yeah, Dr. Deepak Singla is also there.
Okay. All right. So look, this first trial is about zanidatamab along with chemo and tislelizumab, which is an immunotherapy. So we know HER2 positive, unresectable and metastatic G junction and gastric adenocarcinomas we are treating with anti-HER2 therapy, and the trastuzumab along with chemotherapy has become a standard in this. So now this new drug zanidatamab is there, and this trial, so this has got a unique mechanism. It's a dual HER2 targeted bispecific IgG1 like antibody. It's bind to two domains and does some cross-linking of neighboring proteins leading to receptor clustering. It has more internalization and thus has more immune-mediated cytotoxicity as well. And Tisli, we know it's a immunotherapy drug, right? Now, this was the trial design where standard Tresto with chemo compared with zanidatamab plus chemo or plus immuno also. The third arm was plus immuno also. And this was advanced research. So HER2 3 plus or FISH positive. 2 plus with FISH. That was the inclusion criteria here. And this was the sequence of treatment, and PFS OS was tested. And
Sir, Dr. Alok Goyal sir is also there.
Okay, welcome Alok. So now nearly 300 patients in each arm, and if we see the median follow-up is nearly more than 2 years, and there are more events in trastuzumab chemo arm and less events with the zanidatamab arm. So these are the curves now. So 12.4 months median PFS versus 8.1 if we are comparing with trastuzumab, and hazard ratio 0.63, and then if BICR, if we look again, it is similar, and hazard 0.65, and PFS in subgroups, again all the subgroups are benefiting except this ISC2 plus and fish positive, but the number is small here. I don't know whether the power was good enough to this. And this is the OS. Again, OS is again, the curves are separated. 26.4 versus 19, hazard 0.72. And the OS is again, in most of the subgroups, it is better. And this is the again OS in favor of zanidatamab, right? So response rates, so they are higher slightly. So addition of immuno is not leading to much additional benefit in the response rates, but if you look at the duration of response, that is little improved, and these are the adverse events. So diarrhea is predominantly more with addition of zanidatamab as compared to only trastuzumab. Other parameters are quite similar. So diarrhea, nausea is predominantly more, right? So now the question arises, is it good enough? Are we convinced with this data? Zanidatamab is a newer drug. Are we, is this a practice changing thing? Dr. Ravinder, you can go first.
Sir, as we know, this gastric carcinoma or G junction or the adenocarcinoma CA esophagus, all combined, there is near about 20 to 25% of HER2 positivity. And HER2 is such a growth factor. If we can't target this, then we can't get such of a more overall survival. So normally in a TOGA trial, we start with the trastuzumab, and now we have another drug that is targeting both the domains, that is 2 and 4, both, just like trastuzumab and pertuzumab. So the data is a little bit of promising, but as we added the tislelizumab with the irrespect of PD-1 and PD-L1, that is showing the same near about same overall survival. So I think this is a good sign with the trial, but I think this is only a single trial, and lots to go.
So yes, this looks practice changing because beyond trastuzumab, the addition of pertuzumab did not lead to much benefit in one of the trials, right?
Yes.
So beyond that, this is showing some good additional benefit, right? Dr. Bhushan, you agree to that?
So definitely this is going to be a practice changing trial, but some things have to be taken with a pinch of salt because they have said regarding it's basically definitely zanidatamab will outperform trastuzumab. It is going to outperform, but the problem is with the addition of tislelizumab, they have given a blanket cover that irrespective of PDL1, tislelizumab, it provided benefit to all the patients in the form of duration of response, which appears to pull away from the doublet. But mostly in this
Yeah, but
trial,
there was not much difference in the otherwise it
OS
was
was
not
same.
adding much, right?
In terms of OS, it was same,
Yeah.
sir. But if you look at the duration of response, it appears to pull away from the doublets. Uh, Definitely, the patients who have a good who have PDL1 by CPS more than 1 or by TAP more than 1%, they are going to benefit. But in this trial, they have retrospectively looked for the PDL1 expression on the archival tissue. So there could be some quality issues. Around 45%
So
of the
Dr.
patients
Alok,
they had.
yeah. I think
45.
that point is
Yes.
fine. Yeah. So, look, my question to you is ki, why do you think zanidatamab would be superior to trastuzumab? Is it something in the mechanism of action, being it is a biparatopic and look, are you there? Dr. Lok, am I audible to you?
So it's binding to two units and
Yeah. I think there is some problem with my signals, maybe.
hear me?
Can you hear me?
Hello? Can you hear me?
Yeah, now I
Yes.
can hear you. Yeah. Mm-hmm. Hello?
Sir, I think there is some network issue. I think we can.
Is it on my
So
side or?
am I audible? Am I audible now?
Look, I can hear
Hello?
you now, but I was
Yes, yes.
doubting my signals. I don't know whether I am audible or not.
So
No, no, both
so
of you
You
are.
both are
you are
audible
audible.
now.
You are audible.
You are audible,
I'm
sir.
audible, no? Okay.
Yeah, yeah.
Yeah. Am I audible now?
Yes.
Hello. So
Yes,
I'm
yes.
saying it's definitely seems to be a stronger anti-HER2 agent, and it's a clean trial. So they have taken statistically good numbers. They have done a hierarchical testing which is fixed, and they try to show that first that Tislali plus Jenny is better, and then they showed that even Jenny alone can work better. The OS for Jenny alone is not mature. It is 1.01, but it's immature. But looking at all the other things, it seems it's a good addition until we have data for TDXD, which might be a competitor and which might be a better drug. But till that time, if we have available and accessible, it's a good drug, and I will like to give it based on this trial. Addition of
Would you like
tislelizumab,
to
yes,
compare with Keynote? So there is Keynote 811,
yeah,
where chemotherapy with anti-HER2 trastuzumab and pembro was combined, right? That was
yeah,
for PDL1 positive.
yeah,
And but here they are trying to improve the anti-HER2 treatment here by addition of a
yes.
more potent drug zanidatamab.
I think it's more of a more clearer trial we are targeting. We know that with and with target therapy, with HER2 it's not that clear, but we know that with target therapy the immunotherapy effect is not there. But we have seen in lung also. We have seen in few patients that addition of target immunotherapy to target therapy do work in HER2, and HER2 is not clearly a contraindication for immunotherapy. So both the trials have a rationale. But I think because tetralism may be avoided in this thing if the OS matures, and it is a thing. So it's a good option, and I think it's a good trial. Yeah, I will be happy to give it to my
Okay.
patients if it is available and accessible. Yeah.
Yeah, that's great. Dr. Ravinder, so
Yes,
once
sir.
we have used this, let's say you use this in first line and this drug is available to you. What are we going to do in the second line after this? It is going to fail eventually. Zanidatamab plus Tisli plus chemo you use in first line. Would you try TDXD in
Sir,
subsequent line?
of course, sir, I will use TDXD, but I think if this trial goes with only chemotherapy with the zanidatamab and this dual, then I will confirm all these type of things because this lelizumab is also added without the PD1 and PDL1, irrespective of PD1 and PDL1. So there is
Sachin,
a
I have a question.
Yes,
Uh,
sir.
Before embarking on TDXD, I think we should check for HER2 new receptor again on relapse.
Dr. Jatin, the most of the
May
data
do
which
a
says
repeat
apart from
biopsy.
TDXD,
Mhm.
once Toga style, we have also seen that once HER2 agent fail, even if it is HER2 positive, it doesn't work. With weak HER2s, we know that thing. But with stronger HER2s like this and TDXD, we need to see the data. And if it HER2 positive, even second line HER2 doesn't work. If it change to a weaker HER2, even if it HER2 positive in gastric, we know that it doesn't work. With TDXD, we need to see that thing whether it will work, even if it is HER2 positive. So we need to look at the data.
So
We need to wait for data.
yeah, so look, these drugs have more bystander effect. Even
Yeah.
this zanidatamab, the mechanism of action is more potent, and TDXD itself has a very high bystander effect.
So definitely,
That's
that
why
is what
these
I'm
drugs are a
saying.
little more effective in
Yeah.
where
So that is what I'm saying. With
where
this drug,
trastuzumab
I
doesn't
will be
work.
more comfortable giving TDSD, but to even give that thing, I need to have some more
My
data.
question is, are we checking HER2 again on relapse?
Sir, I was not checking because we know that anti-HER2 agent will not work once HER2 fails, and we don't have TDXD data. So that, but yes, I do a biopsy, but I don't rely. Even if it's HER2 positive, I don't add a second HER2 agent once it fails HER2. Till now, I was not adding TDXD data. Definitely, it has bystander effect more potent. Might come out to be positive. Yeah.
My take on this is that we should always check repeat HER2. In gastric, it is different as compared to breast, and the literature also says that HER2 should be checked again once you have failed first line anti-HER2 therapy of any kind in gastric cancer.
Definitely, definitely.
So look, we generally tend to do repeat biopsies and find more NGS marker, which can be done in these patients. That is again we have targeted therapies available for that, and sometimes rarely we get some MET amplification or RET or something which can
So definitely, I want to just put off that unlike breast, if even if it is HER2
more
positive, we don't
targets
have a
as and
data
when
for
the
second
patient
line
progresses.
HER2 at present. Yeah, that is the only thing. Yeah.
Gastric cancer like malignancies may not give much time actually.
Definitely, we need to address. We need to look at target therapy.
Yeah, no?
Yeah. I'm just saying that yes, definitely we do biopsies. We do biopsies, but most of the mutations which are present baseline, and we don't have data that any new mutations come when they progress. So not every patient is subjected to biopsy, and until unless we have data that a HER2 positive agent which works in second line post HER2, सर बहुत ज्यादा प्रोग्रेशन पे म्यूटेशंस आती नहीं है अगर आपने बेसलाइन एनजीएस कर रखा है तो मतलब doesn't make a lot of difference in much
Gastric
of a
cancer
patient.
is a different ball game, na?
Yeah.
The natural history of gastric cancer is not that long to do too many interventions.
Yeah, therefore I do it at
newer
baseline only. I
mutations.
don't repeat biopsy in every patient on. Yeah, don't do that thing. Yeah.
Yeah, may not be feasible all the time.
Yeah.
So we move on to the next one. So now this is a very interesting and exciting development. This Resolute 302 study. And so daraxonresib is a RAS on multi-selective inhibitor. Now, why excitement? Because we don't have anything biomarker directed therapies. Every minute hardly we get any biomarkers, and if we had biomarkers, there was no drug. Now, daraxonresib is a new standard after maybe the first line therapy, but it may soon if it continues to show such responses and betterment of survivals, maybe it can become a new standard. So, Dr. Ravinder, are you
Yes, sir.
also excited about this?
Yeah. Yes, sir. As we know, I think that this pancreatic carcinoma is a little bit of more lethal as comparable to other cancers, and we don't have any such type of targetables in this pancreatic cancer. And we are having, but daraxonrasib is on the second line. So and having a good data that is doubling this OS and there are good result with the manageable side effects. I will prefer this drug as a second line therapy. Definitely, sir.
So, Dr. Manish.
Yes, sir.
You see a lot of pancreatic, unresectable, and borderline, where we tend to give some chemotherapy, but we usually don't get much success in making them resectable. So now we have a targeted agent here. Do you think does it ring some bell, some excitement? This
Sir, I
drug
think
is soon going to be tried upfront in all kind of situations, in metastatic as well as in borderline resectable as a new adjuvant, along with combination with chemotherapy. Soon we are going to have such data. Do you foresee any such thing happening with this?
Or sir, if it is going to give good results and make some of the borderline tumors operable later on, so definitely I would be excited to see the results of this drug in our setup. But as of now, we know that pancreatic cancer, especially the head of pancreas, that behaves very bad, no matter whether we do surgery or try to give neoadjuvant therapy and then try to operate. It's only the periampullary carcinomas where we have seen some encouraging results after surgery. But for this, definitely, if something new is coming in hepatopancreatic biliary cancer and which is adding to the survival of the patients, then definitely I think we should look forward to it. And it should
Dr.
not make the life of the patient difficult. That patient should have fairly good performance status after receiving this drug to come onto the table and tolerate a major surgery.
True. So this is potentially a drug which can move into the first line. Jatin sir, what's your take on this? Dr. Jatin is there? I'm not seeing all the people who are. Okay. Dr. Anuj?
Sachin, I missed what you asked.
I was just asking, what's your take on this drug? The results you see in the
Yeah,
second
results are
phase?
very good.
Mhm.
Results are good, definitely. But it's not available with us.
So is it available on compassionate grounds? Has anybody tried it? Dr. Lok, are you
Yeah,
aware of
yeah.
anything compassionate grounds availability? Or
Uh,
should be something
to
happening
be
here.
honest, I have thought, not got time to see and to get to see whether it's available on compassionate bus, but it seems to be the most practice changing abstract of the plenary sessions of ASCO this time. So this is really a practice changing and open RAS inhibitors. Definitely to come to first line, then they will try it in neoadjuvant setting because the response rates also are definitely partial
Yeah.
response rates are higher. Definitely tripling. So we can have early response rates which can we need to see how early the response rates are there, which is not we need to see the full paper. But if responses are occurring early, it can be a good therapy which can be done in neoadjuvant setting also. It is interesting to see whether they will combine with chemotherapy or not to increase even further, but that is just speculation. But alone also it seems to be a very very effective drug at present.
Yeah. And the curves are speaking for themselves. The
Yeah.
divergence of curves is also happening
Yeah.
early.
So
And these
this
are the
this this is the
response
only
rates.
yeah.
Yeah.
So
But
this is the
Sachin,
only
it
plenary
is not
which got a
available.
But
standing
they
ovation in ASCO this year.
but they did not differentiate the head or tail and body type of the pancreatic cancer. They
Dr.
combine
Sachin,
all these in
your
a
question
single.
of availability, I had a patient. It is
Hanji
not
sir.
available on compassionate, so they asked us to do a biopsy and carry a biopsy to United States, and it was
Mhm.
carried. And, it was found to be positive, and now he is being enrolled. Enrolled 1 year in this trial, so
Okay.
it is not available here with us.
Right, sir. And the safety wise, not too many major concerns. Some stomatitis and rash was there, and discontinuation was also very small. So this rash, diarrhea, stomatitis, nausea, vomiting, these were the main concerns with this. I think we should look forward to this. This is really very important because there's hardly anything we are able to do in pancreas,
So
once the.
sorry to interrupt. Kindly conclude the panel.
Okay, so I think we just spend a couple of minutes on the last one. So this is breakwater. We have earlier also discussed on some forums about this. So anchorafenib, which is a BRAF anti-BRAF drug, along with anti-EGFR Cetuxi, along with folfuri, right, which is a there for metastatic disease. So let's just come to the point. So we have this trial schema here where double targeted along with chemotherapy is being tried. So this is a biomarker directed thing. And so Dr. Bhushan, what would be your take on this? Would you will you do upfront NGAs for all your patients, all your metastatic patients to find the markers?
Yes, sir, definitely. In light of this data from Breakwater plus the cohort 3 data, it supports the testing for BRAF V600, which usually is seen in 6 to 8% of metastatic CRCs.
Yeah, so
And
there's a
plus
small
the class.
percent of patients who would be BRAF positive, and so this data is very important for those. Dr. Ravinder,
Yes,
would you
sir.
use this information? So this drug is quite costly, and core patients usually cannot afford. It's again difficult. Financially, it's difficult. So would you talk about the mechanism? How the combination is helping? So
I
they
think
have
there.
taken cetuximab also here along
Yes,
with
yes, yes.
this.
When we talk about the pathway, the EGFR, the KRAS, RAF, MAP kinase, and the nuclear factors, so we have to block all the factors. If we are blocking the EGFR and then KRAS, RAS, and RAF are mutated, then we don't have any use of using cetuximab or panitumumab in this. So that's why we are exploiting both the markers that pen that RAS and then EGF, sorry, BRAF and then EGFR, both are
EGFR
targeting.
needs to be, yeah. So what
Yeah,
happens is that BRAF
we are
inhibition,
blocking this pathway.
so there is EGFR feedback activation happening here actually.
Yes, yes, yes.
So BRAF must be combined with anti-EGFR, only then it is likely to work more.
Yes,
Alone
yes.
BRAF inhibitors may not give these kind of results. So Dr. Alok, your take?
Yeah, definitely. So we had a breakwater result where we have already seen that Folfox plus this combination already worked, and they wanted to study Folfiri in this because when we combine encorafenib and irinotecan, both are metabolized to CYP3/4, and there is some decrease in irinotecan concentration around 30% which occurs. So they wanted to see whether in those patients where we are not able to give Folfox upfront, whether Folfiri can be a good chemotherapy backbone, and the endpoint is overall response rate. We need that can be argued that how good an endpoint is overall response rate, but they just wanted to prove that Folfiri can be a substitute to Folfox when we are combining with encorafenib because of decreased concentration of irinotecan which happens. ORR is significantly better, but definitely ORR as an endpoint, because OS is not mature, will be difficult to say. But yes, some patient who cannot take oxaliplatin due to neuropathy, this data will encourage me to use Folfiri with encorafenib and cetuximab. So
So I have a
until
reverse question, which Alok,
yeah,
you or maybe Dr. Jatin can also answer. Would you use Folfox in place of Folfiri here?
so there is already data. So initially, Breakwater trial has shown that PFS benefit of Folfox plus EC. So they've continued this to see whether Folfiri
With
can be
irinotecan.
substituted. So Folfox
So
is
what would be
definitely
your choice? Suppose your patient is fit to take both. Would you use
Folfox.
Folfox or Folfiri?
Folfox, because the PFS data is with
Folfox.
Folfox. It is only overall response rate with Folfiri. So Folfox definitely, yeah.
Right. I think so. For lack of time, I'll have to just stop here. I thank all my panelists for this wonderful discussion and hand over to the organizers. Thank you so much.
Thank you, Doctor. Such a wonderful presentation. There was one doubt of trastuzumab after failure of trastuzumab using TDXT. All the three gastric destiny trials were done after failure of trastuzumab, and then they were effective and good responses were seen in that. So with this, we come to the end of today's this topic. I hand over to Dr. Mukesh, please.
Thank you so much, sir. Thank you for the wonderful chairing the session and the moderation and the active participation of everyone. Thank you. So now we move on to the next session, and I welcome Dr. Brigadier HP Singh, sir. Sir is Director Medical Oncology at Park Hospital, Mohali. Welcome, sir, and over to you. Can you invite the speakers? Dr. HP Singh, sir. Sir, are you there? So, I will be moving ahead for the next session. It is rationale to practice role of tislelizumab in esophageal carcinoma. I will be speaking on this. Can someone play my slides, Manya?
Yes, sir.
Sir is there. Sir. Sir, I think you are on mute. HP sir, I think you need to unmute, sir. You need to unmute. Can
So is my
someone?
screen visible?
Yeah, it is visible. I think sir is trying to say something, but he is on mute. Can you call, sir, please? Okay, you continue the slides. Next slide. Next slide. Yes. The next slide. Yes. So till now, around 11 PD-1, PD-L1 inhibitors are approved. Nivolumab was the first PD-1 inhibitor approved in 2014 for the melanoma, but now we have PD-1 inhibitors across indications for more than 10 indications. And tislelizumab and pembrolizumab are the only PD-1, PD-L1 inhibitors which are approved for almost all the indications, starting from non-small cell lung cancer, GE junction, gastric cancer, urothelial, classical Hodgkin's, esophageal, SCC, MSI high indications, and nasopharyngeal carcinoma. Next slide. So tislelizumab is a humanized IgG4 monoclonal antibody with high affinity and binding specificity for PD-1. It blocks the binding of PD-L1 and PD-L2 to PD-1. It is differentiated by its unique binding epitopes. The recommended dose is 200 mg administered 3 weekly. More than 20 potentially registration-enabling clinical trials happened in 35 countries and regions, including 17 phase 3 trials and 4 pivotal phase 2 trials. It has been dosed in more than 13,000 of patients and more than 750,000 patients treated commercially. So we have a vast data about this drug. Next slide. So tislelizumab has a broad global clinical development program. It is indicated in first line nasopharyngeal carcinoma. It is approved for squamous cell, non-small cell, non-squamous, non-small cell, second line non-small cell, and first line extensive stage small cell lung cancer. It is approved for that, apart from small cell in India, European Union, and other countries. And then it is also approved for in China for SCC, urothelial cancer, and a blanket indication in MSI high tumors. Next slide. So major clinical trials across multiple indications: non-small cell lung cancer, rationally 303, 304, and 307, and 315 in extensive stage small cell, 312. Next slide. We will discuss these trials, some of these trials. Next slide. Next. So the structural advantage is it results in the complete blockade of the PD-1, PD-L1 cause of the binding to PD-L1 and 2, resulting in more than 99% blockade. So mechanism of action, anti-PD-1 monoclonal antibody with FCYR binding. Next slide. I think in the shortage of time, we will just skip to the main points. Next. So what is the advantage? In preclinical models, tislelizumab demonstrated high target affinity and slow dissociation, around 100 times slower rate from PD. Its half-life is approximately 30 to 80-fold longer than that of pembrolizumab and nivolumab respectively. The IC50 values of pembro and nivo are 1.3x to 3.5x higher compared to tislelizumab. So it has a lower half maximal inhibitory concentration value, thus having stronger anti-tumor activity. Next slide. Esophageal squamous cell carcinoma. Next. And the rationally 306 trial we will discuss tislelizumab plus chemotherapy versus placebo for advanced or metastatic ESCC in first line. Next slide. So 649 patients were randomized from 162 sites of 16 countries across 4 geographic regions. 75% of the patients were Asians and 25% from rest of the world. Next slide. So eligibility criteria was unresectable, locally advanced or metastatic, extensive stage small cell, esophageal squamous cell carcinoma, no prior systemic therapy, ECOG performance status 0 or 1, and measurable disease. Tislelizumab 200 mg IV 3 weekly plus investigator choice chemotherapy was compared with matching placebo 3 weekly plus investigator choice chemotherapy. 1:1 randomization was done, and the primary endpoint was overall survival in all randomized patients, and secondary endpoints were PFS, ORR, and duration of response. Baseline PDL1 status was used on the basis of TAP score more than 10 or more than 10%, less than 10%. Next slide. So overall survival, tislelizumab group median OS was 17.2 months versus 10.6 months in the placebo group, with a hazard ratio of 0.66 and a p-value of less than 0.001, which is significant. 34% reduction in risk of death and 6.6 months additional overall survival achieved. Next slide. So coming to the PFS, median PFS was 7.3 months compared to 5.6 months with a hazard ratio of 0.6 with a p-value that is significant. So it was significantly improved with tumor response greater and more durable with tislelizumab plus chemotherapy. Next slide. Safety and tolerability. Majority of the side effects were grade 1, grade 2, and it was a fairly tolerable drug. The main side effects, mainly due to the chemotherapy partner, anemia, decreased neutrophil count, myelosuppression, decreased appetite, nausea, and peripheral sensory neuropathy was there. Patients with one or more immune-mediated adverse events were there in 21% in tislelizumab group compared to 6% in the placebo group. Next slide. So indirect comparison of first line esophageal squamous cell carcinoma trials, if we compare rationally 306, which is a median OS of 17.2 versus 10.6, hazard ratio of 0.66, keynote 590, it is 12.6 versus 9.8, checkmate 648, 13.2 versus 10.7, Jupiter 06, 17.1 versus 11, Orient 15, 16.7 versus 12.5, Escort 1 15.3 versus 12, and Estrom 15.3. So giving almost one of the biggest benefits in the rationally 306 trial with the tislelizumab. Next slide. Coming to the rationally 302, tislelizumab versus chemotherapy for advanced or metastatic esophageal squamous cell carcinoma. Next slide. In the second line. So eligibility criteria, advanced or metastatic disease, progression during or after first line systemic treatment, ECOG performance status 0 or 1. 512 patients randomized 1:1. Tislelizumab 200 mg IV 3 weekly versus investigator chosen chemotherapy from among Paclitaxel, Dosi, or irinotecan. So primary endpoint OS, secondary endpoint OS in patients with a TAP 10 more than 10%, and stratification was done based on the PDL1 status. Next slide. So 30% reduction in risk of death happened, 2.3 months additional overall survival achieved, 46% reduction in risk of death in TAP more than 10% patients, and 3.5 months is the additional OS in TAP 10 or more than 10% patients. So tislelizumab significantly improved OS versus chemotherapy in all randomized patients and also in patients with TAP 10 or more than 10%. Next slide. So PFS Kaplan-Meier curves began to separate approximately 3 months after randomization, and the separation continued, and it was associated with a greater overall response rate and more durable tumor response than chemotherapy. Next slide. So it is fairly tolerable in this trial also. Grade 3 or more than grade 3 or grade 4 side effects happened approximately in 18% of the patients in tislelizumab subgroup compared to 55% in the chemotherapy, and they were fairly manageable. Side effects leading to death were in 2% of the patient and leading to treatment discontinuation in 6 to 7% of the patient. Next slide. So PDL1 inhibitors comparison in second line ASCC. 302 Tislely versus chemotherapy, 8.6 versus 6.3 months is the median OS. Keynote Pembro trial, 8.2 versus 7.1, and Nevo versus chemo, 10.9 versus 8.5. So tislelizumab appeared to be better as compared to Pembro and Nevo in terms of OS and PFS. Next slide. So network meta-analysis, tislelizumab versus other anti-PD-L1 agents in first-line treatment of unresectable, locally advanced or metastatic ESCC. Next slide. So what is network meta-analysis? It is a statistical method that compares multiple treatments using direct and indirect evidence. It helps estimate the relative effectiveness of interventions, even if they haven't been compared in head-to-head trials. It helps clinicians and policymakers make evidence-based treatment options, provides a ranking of treatment based on efficacy and safety, and allows comparison of new treatments with existing standards. Next slide. First line ESCC. Next. So these are the 3 trials which have been compared of Nivo, Pembro, and Tislely. Next. So tislelizumab plus chemotherapy was associated with the highest probability of being the most effective treatment and the highest likelihood of being the top ranked therapy. Next. For PFS, tislely plus chemo was significantly more favorable to Nivo plus chemotherapy, and it was associated with the highest SUCRA value of 90% and a PVS score of 71%. Next. For ORR, Nivo plus chemo was associated with the highest SUCRA value of 87% and PVS score of 65%, and tislely plus chemo was comparable to Pembro plus chemotherapy. Next. Next, we will skip these, I think. Next. Just continue. To conclude, in this analysis, tislely plus chemo was the highest ranked anti-PD-1 agent for OS, PFS, and grade 3 or more treatment-related adverse outcomes, and was significantly more favorable to Nivo plus chemo. And collectively, these results highlight the favorable risk-benefit profile of tislely plus chemo and provided a potential rationale for adopting the use of tislely in ESCC. Next slide. Rationale 305, that is in gastric cancer and GE junction cancer. Next slide. So tislely plus Capox or cisplatin 5-FU was compared with placebo plus Capox or cisplatin 5-FU. Next slide. Baseline characteristics were quite comparable. Next. So at the end of 3 years, overall survival in all patients, it was tislely plus chemo, it was 15 months median OS compared to 12.9 months in the placebo subgroup. Next slide. So tislely plus chemo was associated with improved PFS, higher ORR, and a more durable response versus placebo plus chemotherapy. It was 6.9 versus 6.2 months, marginally beneficial, and tumor response was 8 points. Median duration of response was 8.6 versus 7.2 months. Next. Just continue and come to the conclusion. Come to the conclusion. Yes, continue the slides. So tislely plus chemo had a comparable efficacy across OS, PFS, and ORR outcomes to Nivo plus chemo and Pembro plus chemo. Further, tislely plus chemo was not associated with a statistically significant increase in grade 3 side effects compared with chemo alone and Pembro plus chemo, and had lower odds of toxicity compared with Nivo plus chemo. Next slide. So first line is tislely plus chemotherapy demonstrated a statistically significant and clinically meaningful improvement in survival and tumor progression with a better tumor response as compared to chemo alone. In second line, tislely demonstrated statistically significant and clinically meaningful improvement in survival and tumor response versus chemo monotherapy. And in gastric, tislely plus chemotherapy as compared to chemo alone produced a statistically significant and clinically meaningful improvement in survival, tumor progression, as well as response. Next. TAP and CPS scoring. Next. So concordance between TAP and CPS, because mostly in India we get the CPS score and TAP score is not commercially widely available. So if we go for the concordance, it is around 85 to 98% in different of the trials. At TAP value of 1%, it is around 98% agreement. At 5%, it is about 90%. And at TAP value of around about 10%, it is 86%. Next slide. So they are fairly concordant. Next. Next is continue. Next. So NCCN recommendation, esophageal cancer, category 1 preferred regime is first line in combination with this 5-FU plus oxaliplatin or cisplatin for PDL1 CPS more than 5%, equal to or more than 5, HER2 negative adenocarcinoma of esophagus, first line in combination with Folfox or cisplatin for PDL CPS 1 or more than 1%. So it is a category 1 preferred regime in second line or subsequent therapy as monotherapy. In SCC, category 1 other recommended regime. In MSI high or DMMR colon cancer, it is approved in locally unresectable or medically inoperable tislelizumab. Preferred category 2A. In suspected or proven resectable synchronous adenocarcinomas with liver only and or lung only mets, and in resectable metachronous mets with no prior IO therapy. So it is approved in classical Hodgkin lymphoma, gastric cancer we have seen, and nasopharyngeal carcinoma also. Next. So to conclude, next. It is a humanized IgG4 monoclonal antibody with high affinity and binding specificity for PD-1. Mechanism of action we have discussed. Basically, it has demonstrated efficacy and safety across first line and second line non-small cell lung cancer and ESCC settings, besides multiple other phase 3 trials showing positive results in neoadjuvant non-small cell, small cell, gastric, SCC, and nasopharyngeal carcinoma settings. It is approved in India in second line ESCC and first line and second line squamous and non-squamous non-small cell lung cancer by the EMA and FDA for second line ESCC and first line gastric, and EMA alone for the non-small cell lung cancer. So the recommended dose is 200 mg administered by IV 3 weekly until disease progression or unacceptable toxicity. Next. Thank you. So if there are any questions.
I think any questions from any of our colleagues? This drug is available with us, no, Dr. Mukesh?
Yes, sir. It is available, sir. We have used it.
Okay. And how's the experience been like? It's safe?
Sir, it appears to be safe, sir. No significant side effect I have tolerated in few of the patients I have given. And it appears to be efficacious. Rest only trials can tell. It's difficult to give a verdict based on few patients. Yes, sir.
And how do you feel it? Patients are Indian patients responding to it well?
Sir, in few of the patients I have used, there are patients who have responded, there are patients who have not. So I think it will take time for me to individually tell from my practice that whether it is comparable to the older immunotherapies. But I think the data is there to see, and it is a equally efficacious drug at least.
Okay, thank you, Dr. Mukesh, so much. Yeah, Dr. Anuj.
Dr. Mukesh, in which
Yes, sir.
indications it is approved in India?
Sir, it is approved in esophageal squamous cell carcinoma. It is approved in non-small cell lung cancer, and by the US FDA and in
EGC.
European, it is approved in SCC also. It is approved in nasopharyngeal and classical Hodgkin lymphomas also. But in India, basically lung and esophagus.
Okay. First line?
It is approved both in first and second line. In specifically DCGI approval, I think it is in the first line only. I'm not very sure, but it is approved for first and second line otherwise.
Okay. Thank you.
Okay, Dr. Mukesh, thank you so much. And now we're going to the next talk, which is on colorectal cancer. It's about Checkmate 8HW study. And our speaker is going to be Dr. Jagdeep. May I request you, Dr. Jagdeep, to start sharing your slides and your talk.
Good evening, sir. I'm Abid.
Hi, Jagdeep, welcome here.
So, shall I share?
Kindly stop the recording.
So, shall I share my slides?
Yeah, please start.
11 countries where again it was locally advanced or metastatic biliary tract cancer, 20% gallbladder, and 76% was metastatic biliary tract. Median overall survival about 15 months and PFS about 8 months. Response rates about 30 months, 30%. Now, comparison between Gemcis and durvalumab Gemcis. So, one thing of note here is majority of the patients were getting already Gemcis and durvalumab. The numbers are shown there, and the outcomes were in favor of the immunotherapy arm, both for overall survival as well as PFS survival, with even better hazards of 0.59, where in the trial it was about 0.74 or 75. So response rates were also better. Now coming to the Indian data, paper published or this data by Dr. Vamshi Krishna from South, 12 participating centers, and similar about 150 patients were 148 patients were included. But what is the difference? Because of our higher predilection of gallbladder cancers in our patient population, much larger patients, two-thirds were gallbladder, then followed by intrahepatic and then extrahepatic. Uh, Good performance score, which was taken as 2 because that is the real world anyway, were about three-fourths, and almost one-fourth were ECOG of 2 or more. And again, majority were metastatic. So again, the patient distribution showed here and patient characteristics which we were discussing. So median PFS again here was 8.2 months, which is similar to the real world data from Europe. And overall survival in the European data was about 15 months, but here the overall survival is 12 months, comparable to what was seen with the Topaz trial. Again, it is hypothesized, and even in the trial, the hazards for gallbladder cancer were not all that great as compared to cholangio. But that does not mean that there will be no response if the patients are fit and affording. I think they warrant consideration for addition of immunotherapy. So immune-related toxicities were seen in about 7% of patients, similar to what we are seeing. Less than 10% usually is the grade 3, 4 adverse events. So conclusion from real-world evidence was that survival and safety are in line or in sync with what has been seen with the Topaz 1 trial, with median overall survival reaching 1 year. And if we see the ABC2 data, which is the GEMSIS gold standard, the median survival was about 10 months from that study without immunotherapy. So I think concluding my talk, this Topaz 1 trial establishes durvalumab plus GEMSIS as the standard of care for managing patients who have unresectable biliary tract cancer. And adding durvalumab to chemo backbone does not worsen the toxicity profile, showing comparable safety across both treatment arms. Real world evidence from India confirms that the addition of durvalumab to standard chemo improves outcomes for gallbladder cancer as well. Now, as Sir was mentioning earlier, what is our experience? So I think the biggest challenge that we face here is affordability. Majority of these patients are low socioeconomic status, and they are not fit or fit economically. They do not opt for immunotherapy. And I do not have an answer whether the other cheaper versions of immunotherapy, whether we can easily replace, whether I have done that. I have not done it for biliary tract cancer. And I'm happy to hear from others if they have used other immunotherapy agents in this cancer. Thank you very much.
Thank you, Dr. Kunal, for an interesting discussion on biliary tract. Any questions from our audience, please? Dr. Kunal,
yeah.
sorry.
Sir, any experience of using low dose? Like we had a session of low dose immunotherapy. In Durva low dose, have you tried in any patient?
No.
Okay.
So what would be the low dose that you would give?
Actually,
You
sir,
define 500 milligram?
Yeah, when the fixed PAP was not available, we have used in 1 or 2 patients of gallbladder 500 mg. Even we increased the frequency due to financial constraints purely. We increased it to 6 weekly also, and the patient continued to be remission. But based on 1 or 2 patient, I can't give a verdict.
Yeah, I generally do not, I would not advocate that outside of a trial. We do it in the best interest of the patient, but you never know how things are going to span later on. If there is a lot of problem, and I'm telling you from this personal experience, even if you try to do the best for the patient, from your perspective, there can be problems later on legally as well. So I would not advocate that.
Definitely, definitely. Thank you, sir. Thank you for your experience.
Okay, thank you, Dr. Mukesh. I would like to share a little bit experience of my gallbladder. We had it terribly. It was the second most common cancer in state of Kanpur in UP on the banks of River Ganges. And we found this gallbladder cancer was closely linked to the distance from the banks of River Ganges. If your home was closer to the banks of Ganges, you had a higher probability of P equal to 0.00 of getting not only gallbladder cancers, but other cancers also. Secondly, we found was that screening for ultrasound, which have been published also in Annals of Oncology, if you start doing in this high-risk population like in UP and Bihar who are living along the banks of River Ganges, you could pick up about, I think, 0.5% patients who are harboring gallbladder cancer in the tummy and they're not aware of it. And we pick them up and you operate. We picked up 4 out of 800, published it also. All 4 are alive. And then we've got about 8-10 years now. So ultrasound screening and prevention of pollution river Ganges is one preventive way we can get rid of this silly cancer, dangerous cancer called gallbladder cancer. So thank you so much, Dr. Kunal. We go on to our next topic of discussion. It's going to be a panel discussion, and moderating is going to be Dr. Rajiv Gupta. May I request to Dr. Rajiv to kindly call your team for the discussion.
Since you had that such like great data, was there any epidemiological study in terms of the water samples or soil samples, or what was the increasing factor?
We used one known heavy metal, which is level 1 carcinogen, called chromium. It is used extensively in leather factories, which is placed in Kanpur, close to Kanpur, called Jajmua area. So what they do is after tanning the leather, they put the whole chromium into the river Ganges. And half the population of UP and Bihar have got this high level of chromium in their body, which is a level 1 carcinogen. So it's going to affect their future generations also. So I hope that paper we published even for Ganges water. The government of India is taking actions to clean up the river and push all these toxic industries downstream. Let's see how it turns up. Thank you, Dr. Kunal, once again for picking up a very difficult cancer and contributing a little bit to it. Thank you. So can we go on to the next session now? May I request Dr. Rajiv Gupta to kindly call his team and have a discussion on hepatocellular carcinoma, another
Thank you.
difficult to treat cancer.
Thank you,
Dr.
Dr.
Rajiv.
Sri, and thanks, Dr. Mukesh, for inviting me to this August gathering and on this oncology meet. I would like to deliberate on intermediate HCC. And the panelists are Dr. Sachin Gupta. He is a senior director, medical oncology, Max Hospital, Chandigarh. Dr. Javed. He basically was initially in, I suppose, Saura Institute. Now, Dr. Javed has joined Al Mataf Medical Center and Research Center, Srinagar. Dr. Amit Rana. He is a senior consultant at Cancer Hospital, Dharamsila. Dr. Kanupriya Bhatia, consultant medical oncology, Mohandai Oswal Hospital, Ludhiana. Dr. Nitish Garg, senior consultant medical oncologist at Mohandai Hospital, Ludhiana. And Dr. Amit Saklani, he is senior consultant medical oncology at Patel Multi-Specialty Hospital, Jalandhar. Welcome everyone and good evening to everyone. So before setting the tempo for questions and answer and discussion, let me deliberate on the background of
intermediate HCC. So can my slides be displayed?
Yes, sir. Sure.
Sure, please go ahead. So,
So are the sides visible?
yeah, thank you, Tanya. And can you enlarge it? Yeah. So I have been regulated the duty to go for another gray area, which is intermediate HCC. Next slide. Next slide, please. Yeah. The content in this presentation is intent for medical education amongst healthcare professionals only. This is a disclaimer. Next slide. So, as we all know that intermediate HCC is not a single disease entity. We are very clear about very early stage, and advanced stage. What to do in very early stage? Ablation, transplantation are the, and even TACE is curative and having curative intent. But in late stages, it's systemic immunotherapy or TKIs. But what about the intermediate stage, like other solid malignancies like lung, like breast? So, like locally advanced, it is locally advanced or intermediate HCC, and still it's a gray area. It is touching upon at one end in early stage, and it is touching with the systemic chemotherapy or immunotherapy at the other end. So, intermediate stage, as per the liver transplantation criteria, is nodules less than 3 or no nodule more than 1 centimeter in greatest dimension, and thereafterwards either we can go for transplant, we can go for even TACE or systemic treatment. Next slide, please. And the heterogeneity is both in number and size. The size is dangling between 3 to 6 centimeters, or it's more than 6 centimeters. Coming to the nodules, it's less than or equal to 3 nodules, between 4 to 6 nodules, and multiple more than 7. So concomitant in presence of non-metastatic disease, no nodal involvement, and as per the up to 7 criteria, it can be shaded as a green, pink, or yellow based upon the response. So very good response will be amongst the green shaded area. Similarly, poor response will be for the pink shaded area, and very poor response will be for the very advanced intermediate, that is multiple more than or equal to 7 as per the size criteria. Next slide, please. So we all have a dilemma whether TACE alone, that is transarterial chemoembolization, will be sufficient enough to control the disease, to make it stable, or even to go for the cure. Cure is not possible right away. And what is the dilemma? That a low response rate and reduced liver function is observed after repeated TACE alone, and poor response to TACE alone in patients with high tumor burden, that is multifocal or diffuse disease, and very lower efficiency of TACE alone in versus if we apply TACE along with the systemic combination, additional treatment in form of immunotherapy or with addition of other drugs. Henceforth, TACE alone will not be sufficient enough, as far as because this disease itself is in a heterogeneous group, and in this subgroup, there are multiple subgroups which will entail the different treatment modalities. Next slide, please. Next slide. So, in view of the heterogeneity of intermediate HCC, how to decide when to adopt a multi-modular approach or multimodality approach? Next slide. So you can see the Kaplan-Meier on the left-hand side. That you can see that number, size, then Bologna criteria or up to 7 criteria, all are dictating different Kaplan-Meiers. So practically a single label as intermediate, but if you subgroup them as per the size, number, as per the Bologna criteria, or as per the up to 7 criteria, they have different Kaplan-Meier. So henceforth, that means definitely there is a need of additional treatment, or TACE itself is not going to answer every subgroup in the intermediate group of the HCC. Next slide, please. It may not be equally effective for the Barcelona liver cancer criteria also. Encapsulated will have the worst outcome. Similarly, infiltrative will have a less worse outcome as compared to the encapsulated. Confluent or simple nodular will have a better outcome as compared to encapsulated. Henceforth, even the subtype will dictate the outcomes with the TACE itself. Next slide, please. So this is what I was telling, that overall response of TACE as per the modified RECIST may drop from 58% to below 30% in tumors with confluent multinodular infiltrative types of tumors, which accounts for about 30% of the all Barcelona cancer liver clinic patients, and warrants better treatment choices. That means you need to add something more. And overall response in extranodule type of tumor seems better than the above two subtypes, but still inferior to encapsulated nodules. The median overall survival for the patients with confluent multinodular or infiltrative subtypes of tumor are shorter by less than 13 months, which is much inferior to the patient with encapsulated nodules. So henceforth, again the heterogeneity amongst the group itself, and heterogeneity amongst the tumor subtypes also, heterogeneity amongst the size also. Next slide, please. Next slide. So radiological tumor response, whether complete or partial, reduced with each TACE treatment, and progressive disease increase. That means with each TACE, your response rate will keep on decreasing. Henceforth, beyond first TACE, it will 40%, and henceforth 26%, 25%, 25%. And you can see that complete revisions are decreasing from 14% till 8%. As you keep on repeatedly going for the TACE, the rate of progression will increase and the response rate will decrease. Henceforth, repeated TACE will not be a better option. Instead of that, we need to add something more alongside with the TACE. Next slide, please. So correlation between tumor burden and as per the up to 7 criteria, a retrospective study of 224 patients with child pug A who underwent TACE stood for the round staining purpose. The liver function worsened as the child pug deteriorates from A to B. And the risk of liver function deteriorates almost double for the up to 7 criteria. Hazard ratio is almost it's double. And another study comprised of 212 Barcelona B subtype patient with the child pug A liver function who had received repeated TACE treatments. So it kept on worsening from 9 to 14% of each TACE procedure, as I've enumerated. That means repeated TACE is not the answer or modality or the answer for recurrences or for the residual disease. Henceforth, again, to increase the response rate or to have the better outcome, you need to add something more to the confirmed TACE as a single modality in the intermediate subgroup of HCC. Next slide, please. And large scale evidence already amongst the Chinese, as per the chance 001, chance 2201, and chance 02 studies, has in which in the initial study they have added PDL1 with TKI versus TACE, and in another they added TKI versus PDI versus the TACE, and in the third one it is Atezo plus Bevacizumab plus TACE versus TACE plus. So you can very well see the Kaplan-Meier curves has separated out, and the best response had been with the chance 023 study, in which they have included Atezo plus Bev in the one arm. Next slide, please. And that set the tempo for emerging the evidence of systemic treatment in the intermediate HCC. Next slide. So as we all are very well aware of the advanced or metastatic disease, that they have taken shape in form of IM Brave 150, which included or which approved the inclusion of Bevacizumab plus Atezo. Similarly, Rationale, Cosmic, Himalaya trial, Checkmate, then 90W or Talent. So similarly, on the lines of the advanced or metastatic disease, we have come up with the Talent TACE, which include TACE along with the Atezo plus Bev, Emerlin 1, which included TACE along with the Durva plus Bevacizumab. Similarly, LEAP trial 012, which included PEM plus Lenvatinib, and similarly Emerlin 3, which include TACE, Bevacizumab, and along with the Tremelimumab. So henceforth, with the advancement in time, you keep on adding the drugs, and henceforth the Kaplan-Meier kept on separating. Henceforth, we realized that the alone TACE may not be answer for the intermediate group of HCC. Next slide, please. So coming to this case, this is the first case I'm going to present. In 2023, a 6 centimeter HCC in right lobe, no varices, no vascular invasion. So male, performance status excellent, 0. Medical history treated for compensated cirrhosis related to hepatitis C in 2012. No history of ascites or hepatic encephalopathy, that means compensated portal functions. No history of acute variceal bleed, child pug A, and usual medicines, none. So platelet count, then thromboplastin time, albumin, CRAT, Billy, all in normal range. Child pug A, as per the Barcelona liver criteria. Next slide. So initial treatment, this patient went complete resection of liver. So it turned out to be moderately differentiated 6.5 centimeter with vascular invasion and without satellite nodules and 20% macrotubular. Next slide. And afterwards, 6 new lesions appeared. The largest was 2.8 centimeters. No vascular invasion. It was redefined as Barcelona criteria B. Lab results AFP 5, platelet normal. Again, thromboplastin time, then albumin, creat, bilirubin within normal range. So now coming to panelists, after that, putting forward that alone taste may not be answerable. You need to add systemic treatment. And this tumor, this case study is presenting to us that repeated treatment modalities were needed. So let me start with the senior most guy, Dr. Sachin, how to proceed in this patient. Dr. Sachin, are you available?
Yeah.
Yeah.
Yeah, I'm here.
Yeah.
So this patient has had recurrence. And so how long was the treatment interval between resection and these new nodules appearing?
So let me go back. Go back to previous slide. So initial treatment was in 2023 September. Next slide. And recurrence was practically, it's almost new lesions appeared and December 2023. So I think they have not mentioned what is the time duration between that, but hopefully
within few months, huh?
Within 3 months they have appeared with the new 6 lesions.
This is a little unlikely scenario. Anyway, so new lesions have appeared. So there is no extrahepatic disease still. So we have investigated for extrahepatic. We have ruled out all the extrahepatic disease here.
Yeah.
And so we need to evaluate the hepatitis status as well. And do a PIFCA test also. His AFP is still in the normal range.
Everything is normal. Albumin, creat, bili, everything is normal.
But the patient is cirrhotic, right?
Yeah. Background of cirrhosis, hepatitis C in 2012.
So I will take my liver transplant surgeon also into picture and rule out any extrahepatic disease, then for and intervention radiologist also, and then formulate a plan for this patient. If the patient is fit and child pool A, he's still child A, right? And
no, this is now it's a basically not Barcelona. Yeah.
So I think a possibility of liver transplant to treat cirrhosis as well as SCCs also should be considered here.
Okay. So
And
you are
if that is not possible or feasible or patient.
Well,
Yeah.
what other options? Supposingly transplant is not in the preview.
Yeah, if transplant is not there, then the liver-directed therapies like TACE and along with systemic therapy, then that option will come in. But I will definitely try to evaluate for possibility of liver transplant.
Liver transplant because of absence of extrahepatic disease.
Yeah.
And still the patient is childbirth A and intermediate.
Is relatively young also. Patient is 57 only. Right.
So that's a good option, I suppose. Dr. Javed, your viewpoint?
Good evening, everyone. So I think a number of lesions, as you have mentioned, are 6, and we don't know is a unilobar or bilobar. Resection has been done initially, so I don't think so. The transplant would be an option in this patient, even though it's a child class A and BCLC B option in this class. The systemic therapy would be the ideal, and nowadays it is changing. The paradigm is changing. If you plan somebody with one modality of treatment, we will not say that the other modality is contraindicated. So there's a shift in management. You will downstage the disease and again reevaluate whether it will be possibly for another form of treatment, whether a local regional or sometimes a transplant after that. So things are changing. So upfront, I say not fit for the transplant, but if you downstage the patient and see what are the other modalities you may go for, whether the TACE or transplant, and go on looking at other options to have longer survival, possibility of cure also. So now I will say the systemic treatment would be the ideal, and then re-evaluate after 3 months. Where we go for whether you go for the case, you go for other models of treatment.
So practically, you will consider that one of the systemic modality has to be in the place.
Initially systemic modality.
Okay. Dr. Amit, your take?
Yeah, sir. As per me, transplant is out of the way, because if you look at the criteria of 7, even there are 6 new lesions size to 2.8, that adds up to more than 7. And again, the lesions are 6, so it takes out the transplant out. So what we can practically out the transplant thing. So what we can do is give some systemic therapy. It is BCLB. So we can go with the systemic therapy, downstage the disease, and then look at the modalities, what the presentation is after 3 or 4 cycles. So that would be best.
So your take is that since up to 7 criteria, it's a transplant is ruled out.
Yeah.
So I'll come to that. What systemic therapy we can consider? So your Kanupriya, are you available? Dr. Kanupriya?
Yes, sir, I am available.
Please, you share your views.
Yes, sir. I also think that I would start with systemic therapy in this patient, probably downsize the tumor, and then image in next 3 months or after 3 to 4 doses, and then decide if I can add any other treatment like TACE or TARE if it can be added to, if it is required.
Okay.
Yes.
Okay, and Dr. Nitish?
Yes, sir. So I agree with the Dr. Kanupriya and Dr. Rana. So only one thing I would like to know is what was the histopath of the resected specimen? Was it a poorly differentiated carcinoma that it has reoccurred within 3 months post resection? So, or if the pre-surgery MRI, triple phase MRI was done to know what was the status, are there any other nodules in the lung, liver or not?
So I think histology has not been mentioned. I have been given the ready-made this case study. But anyhow, irrespective of the histology, let's assume that it is one of the best histologies available. Even then, I think
systemic therapy, sir. Systemic therapy first, reassess.
Yeah. So practically, since as up to the 7 criteria, which is the best criteria right away, which is evaluatable, and according to that, if you just if you multiply right away, it is going beyond 7 centimeters. So henceforth, I suppose systemic therapy, as other panelists are saying, that should be considered as one of the first options. Sachin has really opened up another discussion point. We'll come to that later on. And Dr. Amit Siklani, are you available?
Look, Dr. Rajiv,
Yeah.
look, liver transplant is a curative option that treats cirrhosis as well as the malignancy, right? Other modalities will only buy time. So wherever possible, this patient has a very early recurrence. So systemic therapy is the point is valid. Ultimately, we are going to give systemic therapy downstage and then consider these things for this patient. But these wherever extrahepatic disease is not there, and these lesions are small actually, so they are distributed, they are multiple, but they are small and still relatively small in size. In such patients, liver transplant is still possible in a lot of cases.
We
So
have
that
not
can be
ruled out.
considered at some point of time. Yeah.
I we have just hold on. Amit. We have just kept your option as one of the option. It has not been negated out, and it's a principally it's a very good option, which I think we should consider definitely. Dr. Amit, are you available?
Yes, sir. Yes, sir. I am
Yeah,
available.
please, you share your view. What views you have right away?
I think
Recurrence within a span of 3 to 4 months, and 6 new lesions has appeared. Despite the fact child pug A patient is there, it's intermediate stage as per the BCLC criteria.
Sir, I think there are various other criteria for liver transplantation. Not only up to 7, there are many others followed across the world. So I think, sir, we should take the opinion of liver transplant surgeon.
Okay.
Upfront, because that is the only curative option. So there are many other criteria which are followed in different centers across world and India. So if there is no extrahepatic spread and also AFP is very, very low, so I think liver transplant should be taken consultation of liver transplantation.
Okay. So Dr. Amit and Dr. Sachin are of opinion that liver transplantation is a curative intent modality, and whenever possible, it should be tried. And rest of the panelists are of opinion that systemic therapy should be applied to downstage the disease. And once disease stands downstage, we can plan for some other modality or whatever modality is best possible at the point of time we should try. So next slide, please. So what should be your treatment goal? I suppose this has been ascertained. What should be the priorities for this patient? So majority of two panelists wants that curative intent should be kept up front, and rest of the patients panelist wants that what best possible is as per the need should be done. And now, what would you combine TACE plus systemic therapy? I think majority of the panelists are agreeing that systemic therapy should be combined with the TACE. Next slide, please. So to add upon, Talentase basically was a study which was a phase 3 trial that, and later on Emerald 1 and Leap 012, which combined TACE with one of the PDL1 and bevacizumab. And out of all the studies, on demand was added in Talentase study itself. Next slide, please. So Talentase was a phase 3 randomized multicentric open label trial of atezo plus bevacizumab versus TACE in intermediate stage at CC. Next slide. And I will not go into the details. So it was a well-balanced 2 arms. It was atezo plus bevaci every 3 weekly, and in the control arm, it was an observation post-TACE. Next slide. So almost it was well-balanced between age, sex, performance status, country, presence of venoportal involvement, then BCLC staging, childbirth staging, and etiology. Next slide. So you can very well see that on Kaplan-Meier that it was once it was investigator assessed a TACE PFS primary endpoint, it was statistically significant improvement with the addition of atezo plus bev. Henceforth, only alone TACE was not sufficient in intermediate stage. Hence, we need to add systemic therapy, and Talentase definitely revealed that addition of bevacizumab plus atezolizumab is going to increase the PFS. Next slide. Similarly, there was a meaningful improvement observed with addition of atezo plus bevacizumab as per the investigator end. Next slide. And OS has not reached yet. You can see the median has not reached yet, but definitely there is a separation of both the curves, which are later on intermingling with that. And in intermediate stage, PFS possibly is a gold standard. Most probably OS may not has been reached yet. Next slide. So as per the overall response rate, you can very well see that response rate is better as per the addition of bevacizumab plus atezo versus TACE only. Next slide. And coming to the adverse events, this treatment-related adverse events, we expect proteinuria, post-embolization syndrome, AST improvement more in the TACE plus bevacizumab versus TACE alone. Next slide. So in conclusion, this study definitely added the addition of atezo plus bevacizumab to TACE resulted in statistically significant clinical meaningful improvement TACE versus TACE alone, and it was 11.3 months versus 7 months. And it was statistically significant and clinically meaningful improvement in PFS as per the RECIST 1+1 criteria was demonstrated. It was 10.3 months versus 6.4 months. And Talentase was the first clinical trial to demonstrate efficacy and safety of on-demand TACE combined with atezo plus bev, suggesting that a new effective treatment option for patients with statistically untreated intermediate to high risk burden HCC. So henceforth, definitely in this patient, if we add on systemic treatment along with the TACE, you are going to get benefit of TACE, and OS benefit seems to be as per in the study. So it has not been reached yet. Next slide, please. Now coming to the case 2, January 2024, TACE plus atezo, partial response after 4 cycles and maintained after 8 cycles. Well tolerated, no adverse events. So you can see that after second and between third cycle, 1 TACE was done between 6 to 7, second TACE and on demands between 7 to 8. So 3 TACE has been done along with the atezo plus bevacizumab has been done initially. Next slide. So treatment coming to a liver section has been done. So 4 moderately differentiated between 3 to 4 centimeters of lesions, vascular invasion, and by July 2025, complete response. There was no recurrence. So next slide. Do you consider TACE PFS as a relevant endpoint or only PFS when combined modalities being considered? Sachin, I think your point is well taken at this point of time that in this patient, TACE has been done repeatedly, and resection was taken in the end. So, what you think? What was the relevant point which was considered?
This all depends upon the area of the liver involved, how much residual, liver would be there, once you uh, do repeated TACE. All these factors have to be considered. So if the rest of the liver is good, and you are not damaging too much of the adjoining liver with each repeated TACE procedure, until then you can go on doing it. So this case, I think the rest of the liver is still quite functioning well. That's why this could be possible. And
So,
twice
let me
resection has been done also, right?
definitely. So, in this case, the majority of other liver portion was uninvolved, and this was limited to only one site of disease. And post TACE and on-demand TACE and with BEF Atizo, there was good response. Henceforth, patient was made resectable. So that's why resection was carried out. So what do I wanted to know that are we were considering PFS only a relevant point or response rate? That means at one point of time, this much of response should be expected. Henceforth, we will plan for a liver transplant. Or it was a PFS, which was endpoint that we may proceed to a transplant or we may proceed with a continuation systemic therapy.
Look, if we have to do liver transplant, we can choose to do that at, it could have been done, once the response was there. Then you're not waiting for it to progress and then again do TACE, and then at the end, when nothing is available, then you are trying for transplant.
So in this patient, 3
So
on-demand
that's
TACE
not
were
the
done.
way.
Yeah. So in this patient, 3 TACE were done before a transplant, before a resection was carried out.
So it was resection, not transplant.
So henceforth, in this patient, resection was possible. And by any time, any point of time, if the resection was not possible, even then we would have considered transplant.
Okay, it would depend again on the liver status. And if the disease is still not spread and it's limited or under control, and then in this particular case, it could still be possible. Why not?
Okay. So Amit, so in this intermediate HCC, where goals may include downstaging and or prolonging TACE eligibility, how important is achieving a overall response as compared to demonstration OS benefit when selecting a therapy?
OS benefit is the gold standard, but till now, most of the studies have not been able to show us OS benefit with the different modalities. So, what is a surrogate marker we are using mostly is the PFS only. So most of the studies have shown benefit with TACE PFS. So we take it as a marker because on-demand TACE is being done. And what are the markers we are taking, like progression, spread, or stable disease? All these are taken care in the TACE PFS. So this is the marker that is being relevant now in most of the studies that we are using to judge
So
the
in
response.
your practice,
Yeah.
if such patient comes to you, so your prime goal is a PFS.
Goal is OS, but I have not data to tell that without transplant I can't tell him that this is the OS benefit I'll get with this kind of a treatment. So I have only surrogate markers
Sorry
like the
to interrupt,
PFS.
sir. Kindly conclude the session.
Yeah, just please give us 5 minutes more.
So right now I'm telling my patients that this is the PFS benefit I can get in form of non-progression, stable disease, and quality of life that I can give to them.
Dr. Javed, your take. What is your endpoint while treating intermediate HCC?
First important thing would be the PFS, whether it will be TACE PFS or with the systemic disease PFS with systemic therapy. As Dr. Amit relevantly said that our goal is that to improve the quality of life. It's it's not a curable disease at this point of time. So you have to improve upon your PFS and check every 3 to 4 monthly what is the status of the disease. You may add further treatment plans, like you may taste, you may go for the resection, and you may go again with the systemic therapy. As I said at the beginning, it's now continuum of care in the SCC. So at every step, you may check for what modalities you have and what you can offer to the patient. Depends upon the comorbidity status, liver function status, and residual liver function. So all those things. So PFS is our relevant point for all diseases where the cure is not possible. So I think relevantly said, yes, PFS. We should focus on more PFS, better PFS. The objective response rates would be also likely good if we have a good PFS in patients. Then survival also improves with that time once you give all the models of treatment in these patients.
Practically, for locally advanced disease or such disease which are not resectable upfront, PFS seems to be gold standard.
Yes.
Yeah. So, Dr. Kanu, what would you like to sequence strategy for the combination of TACE plus systemic therapy? Would you like to combine in your practice?
Sir, if we take the case that you had presented, that was a recurrent disease. And to me, it felt that the intent there would be palliative, and that is a case, or there are certain intermediate cases like a very diffuse infiltrated, like you said, or a conglomerated HCC, we know will have a poor prognosis. So those are the patients I would actually like to combine TACE with systemic therapy. But in all patients in this heterogeneous group, I don't think we have data enough to combine systemic therapy for all patients of intermediate HCC. Two trials have already shown that there is no overall survival benefit, the Emerald and the LEAP-1 trial. The OS data of the trial that we are discussing today is still due. So I'm not really sure how much we are justified on using the systemic therapy before progression in our patients. So if an upfront patient of an
Hello,
intermediate stage.
Rajiv sir, can we request you? Discussions are going brilliant. Hello, Rajiv sir,
Yeah,
excellent
yeah.
discussion.
Tarun, just 2 minutes more. I waited for 15 minutes more. At least wait for 2 minutes for us. Okay.
Okay. Sir,
Thank you. Thank you.
I leave
Thank
it to
you.
you.
Yeah, you just it's a practically it's 9:08, 9:15 we will close once for all. Okay.
Yes,
So
so
Dr. Kanu,
just to
please continue.
yes,
I
just to
can take
keep it
this much of
short,
liberty from Tarun.
so an upfront patient with an intermediate stage coming to me, it's a very heterogeneous group. Every patient would be treated differently. For all patients, I would not like to combine TACE and systemic therapy.
Okay, in your practice, you are comfortable with which modality? If suppose by any chance, if
Yes, sir.
this patient says that I would like to combine with the systemic treatment, what
Yes, sir.
systemic treatment you are using in your practice for
Sir,
the knowledge of others also?
so basically in BCLCC, we have more experience with using atezo-bev. So I would end up, I have not actually encountered a patient, but if I have to, I would use atezo and bev only in these patients.
Okay, so you would like to be more comfortable with atezo plus bev.
Yes,
Okay.
sir.
Okay. Dr. Amit Siklani, how you foresee the combination of TACE plus system treatment in coming times?
Yes, sir, definitely. I think OS data is not yet mature with Atizo plus Bev, but I think PFS is okay. We can use it, and we will be using it. And definitely, I think in the future also PFS with PFS taste benefit, then we can combine the. We have data at least for
Any
P.
of your experience in using some system treatment along with the TACE?
No, sir,
I know Patel Hospital is a very, it's a, I suppose, it's one of the big centers of oncology in Jalandhar. So you don't have an experience
no, sir, no.
in-house? Okay. So please, next slide, please. Next slide. Please skip the slide. I just would like to, next slide, please. Skip and come to the last two slides. Next slide. So what happened to this patient? I just want to let you know. Next slide. So as per the conclusions of this ABCC I think I would read it out that result, even if we can substitute TACE with the combination of atezo plus bev, and it was a second interim analysis which showed a better superiority or superiority of the systemic treatment as compared to TACE with regard to treatment strategy in intermediate stage SCC. Next slide, please. So, which intermediate HCC would you like to go for approach? Would like to benefit from TACE? Dr. Sachin, one word from you. Which is the subgroup which is going to get the best benefit out of the TACE plus atezo plus bev?
So look, if you have discrete, nodular lesions, then TACE would be a better thing to do first. But if you have a diffuse infiltrative and more spread out disease, and too much of disease, then I would go for systemic thing.
Okay.
Mainly.
Dr. Amit Rana, what do you think who are the patients who will get the benefit maximum from TACE alone?
TACE alone will be a solitary kind of a lesion with good portal venous flow is there, and we don't have any other multiple lesions are there. But if I have a diffuse or a multifocal kind of a disease with portal vein invasion, then I'll go for a systemic therapy first.
Okay. Dr. Javed, according to you, who are the subset of the intermediate HCC patients
I
who
will
are going to
concur
the best
with,
benefit from the atezo plus bev alone?
yes, I will
No
concur
TACE.
with both of them that if there is VP3, VP4, yes, you don't go for the TACE. Yes, there you will go for the systemic treatment, and the rest criteria like encapsulated discrete lesions. Yes, TACE is possible once there are no venous or portal venous lesion in their involvement.
So practically those patients who doesn't have an involvement of portal vein or those who don't have a vascular invasion, they are the patients who are getting the best benefit of the
Yes.
treatment modality. Next slide, please. Next slide. So this is already discussed. So I have to hurry the slide, but it was a really fruitful discussion. Thank you, all of you, as a esteemed panelist, and those have contributed a lot in understanding the intermediate HCC. And thanks to Dr. Mukesh Bansal for providing us an opportunity.
So, thank you so much, Dr. Rajiv sir, for a
Thank
very nice discussion. Now over to Dr. Mukesh to invite the next speaker, please.
Yeah, just a minute. Thank you so much, sir, for the wonderful discussion. I just wanted to ask one question. Have you any experience of using a Tizo plus web with TACE? And if yes, then how many cycles before TACE you think are best?
Very limited experience, only 2 patients in my experience. Those underwent TACE and then they were on systemic treatment with the atezo plus bev. One of them patient is from Srinagar, and I suppose Dr. Javed Muzammil is also looking to that patient. It's more than 2 years now.
Okay.
Yeah, this patient I recall because he's getting atezo free of cost. Henceforth, that's why I'm remembering. It's more than 2 years. And second patient couldn't fare well. I'm not aware of the histology, whether this was diffuse, but that patient failed after 4 to 5 months and to underwent again repeated TACE. And because of financial constraint, I think he left the atezo arm. And now I'm continuing with the bevacizumab because it's available free of cost to us. So these are the 2 patients in my experience which I have seen. Those have taken care with the TACE along with the on-demand TACE and with continuation of the systemic treatment.
Thank you, sir. Thank you for the
Thank you.
moderation.
Thanks,
Thank you for
everyone.
sharing the
Thanks
experience.
for the
Thank you
panel.
so
Thanks,
much, sir.
panelists. Thank you.
So now we are moving
Thank
to
you,
the
sir.
next session. And for the next session, I welcome Dr. Sandeep Kukkar, sir, Director Medical Oncology, Park Creation Hospital, Mohali. He will be speaking on redefining outcomes in bladder cancer, evolution of PET-CEP in first-line locally advanced and metastatic urothelial carcinoma. Over to you, sir.
Thank you, Dr. Mukesh. I hope I am audible.
Sir, we can see you well and you are absolutely audible. You can share your slides, sir.
Just a moment. Are the slides visible?
No, sir.
Not yet, sir.
Not as yet. Okay.
No, sir, slides are still not visible.
Just a moment, Dr. Mukesh. Just a moment. Okay. Okay, you can share it from your side. I think there is some problem. I'm not able to.
Sir, we are sharing.
Okay. So thank you, Dr. Mukesh, and for giving me the opportunity to discuss something on which has changed the front line of treatment in the last 1 or 2 years. And the evolution of this trial actually goes back to approximately, I would say, 6, 7 years back. Why? Because this trial was designed because platinum chemotherapy had already reached its therapeutic ceiling. It has been the frontline treatment or the forerunner of treatment since approximately 2 decades, where we all know that with standard chemotherapy arms cisplatin and gemcitabine, it usually offers a progression-free survival of approximately 6 months and an overall survival of approximately a year to 14 months. But again, developing on something on from what has been there on the cards since last few years, we came on to know that immunotherapy is something that actually works. So keynote 052, it clearly stated that the overall response rates are to the tune of around 30%, and the patients who responded, they continued to respond, and the responses were pretty durable. So we believe that immunotherapy is one agent that could potentially benefit such patients where we want some durable responses. Going forwards, we also came to know that there is an antibody drug conjugate like enfortumab vedotin with the trial EV201 and 301 that it works in a metastatic setting. Why? Because there is expression of Nectin-4 in approximately more than 95% of the bladder or urothelial cancer patients. Next slide, please. So this is a brief about how the things actually started from the chemotherapy backbone to immunotherapy and then combining immunotherapy with the antibody drug conjugates. So there was a biological rationale behind why we chose these two agents to combine. Next slide, please.
I think slides are not moving, Manya. Please see to it.
Slides are not moving, yes. So this was the biological rationale behind combining two different therapies. One was an antibody drug conjugate and the other was pembrolizumab, leading to more immunogenic cell death, more antigen presentation, leading to building a cold tumor into a hot tumor, and then immunotherapy can take over, and then uh, maybe you can have a durable response with the continuation of immunotherapy. So basically the rationale was to kill the tumor with EV, which primes your immunity, and giving pembrolizumab, which sustains that immune response and builds up that durable responses.
Daud, please share the slide deck.
So I think this was an important trial which actually included more than 800 patients which were previously untreated, first line, uh, unresectable, metastatic urothelial cancers, and it also included the arms which were actually cisplatin eligible versus ineligible, and the arms were equally randomized between EV and Pembro versus the current standard of care, that is gemcitabine and a platinum-based chemotherapy. Can somebody share the slides, please? So the primary endpoint of these trials were progression-free survival and the overall survival, and the trial met its primary endpoint with a hazard ratio of approximately 0.4, and there was a doubling of the survival benefit as well, and there was a progression-free survival benefit as well. Approximately, yes, please go ahead. So go to the previous slide. Yes, so this is the EV302 design, which I was talking about, that more than 800 patients were randomized between two different arms, EV Pembro versus giving the chemotherapy backbone, that is cisplatin and gemcitabine. And the primary endpoint was a progression-free survival and an overall survival. The stratification factors that we usually see are the platinum eligibility versus ineligibility, PD-L1 expression high or low versus the presence or absence of liver metastasis. Next slide, please. So the arms were equally balanced between the two, and the baseline characteristics were almost very similar. There were equal proportion of patients who actually had upper urothelial cancers compared to the lower urothelial cancers, which were predominantly more in number. And the kind of presentation that we see in the platinum eligibility was almost very similar, to the tune of approximately 50%. Next slide, please. So 33% of the patients in EV and Pembro, they remain on treatment at the time of analysis. I'll come to that. Next slide, please. So fair proportion of patients who are actually on treatment. So this was the primary endpoint, which clearly stated that there is doubling of the progression-free survival, 12 months versus 6 months. Next slide, please. And approximately 55% of the patients were without progression after being on EV and Pembro for a fair proportion of time. So the subgroup analysis also stated that irrespective of PDL1, irrespective of platinum ineligibility, and irrespective of presence of liver metastasis, the drugs, the combination equally benefited each and every proportion. Next slide, please. So the overall survival also depicted a very similar picture, that the hazard ratio was approximately 0.47, that is 50% of 53% of the patient, there was a reduction in the risk of death, and there was approximately doubling of the median overall survival. Next slide, please. So this is the subgroup analysis that we were talking about: eligibility versus cisplatin eligible versus ineligible, presence or absence of liver metastasis, and the presence of disease in the upper and the lower urothelial tract. The quantum of benefit was also very similar, and the hazards were again to the tune of 0.5. Next slide, please. So the most important question, whether PDL1 plays a role in detecting those patients who can be benefited more with the addition of pembrolizumab, like we have seen in the other cancers. PDL1 expression here is irrelevant whether you have high or versus low. The quantum of benefit would remain the same. Next slide, please. So in the Asian population also, PFS and OS were very reflective of that we saw in the ITT and the original trial subset. Next slide, please. So exploratory endpoint, because we all know that these are the kind of patients who are actually elderly. So we have, every time when we treat these patients, they are beyond 70 years of age, and we have that concern that the patient would be able to take or tolerate the total entire duration of therapy or not. So the exploratory analysis showed that the benefit in terms of PFS and OS was very similar. That is, almost doubling of the overall survival was seen with the hazard ratio of 0.5. Next slide, please. So this is what we see is the consistent in each and every subgroup of the patient. So the OS and PFS across subgroups, it was very similar, and it also benefited patients who were elderly and who had a fair proportion of patients who had actually suffering from type 2 diabetes mellitus, and the benefit you can see from the Kaplan-Meier curves, it's very similar. Next slide, please. So in terms of diabetes and in terms of low GFR, also less than 60 versus more than 60, the PFS and IOS benefits with EV and Pembro, they were very consistent to that of the ITT population. Next slide, please. So the subgroup analysis of OS was again very reflective of what we saw with the PFS curves, almost very similar, whether you have a tumor in the upper or lower urinary tract, whether you have presence or absence of liver metastasis, and lastly, the presence of PDL1 expression was irrelevant to the use of EV and Pembro. Next slide, please. So the response rates were pretty high. We all know that with chemotherapy backbone, we have responses to the tune of approximately 30 to 40%. And the proportion of patients who actually achieve CR is only 10%. 1 out of 10 would achieve a CR with the ongoing chemotherapy. So here, the proportion of patients who actually benefited was to the tune of approximately 70%. Response rates pretty high, and the number of patients who actually had complete responses was again 3 out of 10. So 30% of the patients had complete responses compared to 10% of the patients with only chemotherapy. Next slide, please. So the duration of response is also important. The kind of treatment that we are giving is more effective, more durable response, and the duration is again sustained over a period of time. You can see that EV and Pembro, the duration is sustained up to approximately 2 years, 23 months versus 7 months. Approximately 3 times jump in the duration of responses. Next slide, please. So the crux of the story is whether the patient is PD-L1 positive or negative, whether the patient has liver metastasis, whether the patient is elderly, whether the patient is platinum eligible or ineligible, having a tumor in the upper and the lower urinary tract, or a bladder primary tumor. There is a broader subgroup of population which is benefited with the use of EV and Pembro. So the duration of response, again, the responders by platinum in the eligibility and ineligibility, all the responders, they favored EV and Pembro compared to chemotherapy, and it was irrespective of this cisplatin eligibility. Next slide, please. So OS in all the CR and PR, and we all know the patients who actually have a complete remission, they tend to live longer, they tend to have a better overall survival compared to the patients who do not actually achieve complete remission. So this is again depicted in this very similar curves that you are seeing in the EV and Pembro arm compared to chemotherapy. Next slide, please. So the time to response and the conversion from PR to CR, so there is a median time where CR is achieved and there is a median time where PR is achieved. So over a period of time, you can see for patients who achieve CR in approximately 3 to 4 months, there will be fair proportion of patients who will actually be converting from PR to CR with the ongoing EV and pembrolizumab. That is, the ongoing responses are enhanced as you continue with the therapy going forwards. Next slide, please. So again, duration of response by a blinded independent review committee in patients achieving CR was better with EV and Pembro, and it was not reached compared to 16 months with chemotherapy. Next slide, please. So this is an interesting trial which showed that each and every subgrouping is benefited in terms of, and patient those who are achieving complete remission even with EV, Pembro, and chemotherapy, the OS is again showing not achieved. Next slide, please. So achieving CR would make sense in patients, those who are being treated, whether it is with chemotherapy or whether it is with EV and Pembro, but the probability of achieving a CR would be better once your patient is on EV and Pembro. So again, you have to put the best foot forward in patients once you are dealing with a patient of urothelial carcinomas. So 60% of the patients received subsequent PD-1 and PD-L1 inhibitors compared to only 1 or 2% because Pembro already included immunotherapy. Next slide, please. So the proportion of patients who actually had toxicities, we all know that the drug is bound to cause peripheral neuropathy, rash, pruritus, hyperglycemia, fatigue, and alopecia. So these are some of the important side effects that one should take care of, and there are immune related side effects also compared associated with pembrolizumab, that is pneumonitis, hepatitis, colitis, and the thyroid dysfunctions. But I think with time and again, as we have we have been accustomed to use immunotherapy in our day-to-day practice along with chemotherapy. This would be a matter of concern, but I think as we gain more and more experience, one would definitely look forward towards the right candidates before choosing their patients on EV and Pembro. Next slide, please.
Yes. Sir, sorry for intervening. Need to conclude, please.
Yeah, there are two more slides. Most frequent side effects with EV and Pembro, if you look at the median duration at 1.5 years and median follow-up of 2.5 years, the proportion of toxicities and the grade of toxicities again remains very, very similar and very, very consistent to what we saw at a median follow-up of 1.5 years. Next slide, please. So again, we are bridging a trial to the real world practice, because again, as I have highlighted, those important subgroups where EV and Pembro needs to be taken into practice in a real world practice, because again, from India we have very few studies where the which actually highlight the importance of adding EV to pembrolizumab. So we all have been using pembrolizumab in the second line, but now it is the time to take it to the front line, looking at the EV302 data. And I think once you go through this trial and the background of the history of this trial, I think you'll be more and more convinced that this is one of the regimes. But again, with a word of caution that one definitely should emphasize upon identifying those early sign and symptoms, and identifying those patients which are at risk of toxicities, particularly skin reactions, neuropathy, pneumonitis, and hyperglycemia. But I think with time and again, as we gain more and more experience, we'll be accustomed to it. Next slide, please. So again, the adverse effects of special interest, I've already stated that. Next slide, please. So onset of selected adverse effects. So it is important because there are skin reactions which appear earlier. So you need to look at, you need to have a proper dermatological examination early. Then again, pneumonitis approximately sets it at approximately 2.9 months. Then you have grade 2 or grade 3 depending on your patient. That is, early signs are picked up in 3 months, and then the full-fledged development of symptoms is approximately 4 months. And then it goes on to development of peripheral neuropathy, which approximately takes 5 to 6 months to develop. So the hierarchy of symptoms would go like this: dermatologic first, pneumonitis, and then going on to the peripheral neuropathy. Next slide, please. So the current guidelines also update in the usage of the sequence of treatment or the treatment paradigm, particularly in the metastatic urothelial cancers. And all the guidelines state that EV and Pembro, particularly if your patients are eligible in a metastatic setting, and secondly, if they are not eligible, then we all try our hands on gemcitabine based chemotherapies or gemcitabine with carboplatin based chemotherapies. Next slide, please. So the paradigm has changed in the last 2 years, and EV and Pembro has come up as a frontline treatment, provided we need to select our patients appropriately. Next slide, please. With this, I think this is the end of the presentation, and I thank Dr. Mukesh, and I thank everyone who has been here around. Thank you.
Thank you, sir. Thank you for the excellent presentation. Can you share your practical experience of using EV plus Pembro in metastatic setting, or if you have used in neoadjuvant settings?
So, Dr. Mukesh, I have not used setting. I have not used it in frontline setting. I have
Okay.
used it in second line setting. Once my patient progressed on cisplatin and gemcitabine based chemotherapy. So he did reasonably well, but again, finances were a limiting factor. So the patient could continue only for 3 cycles and then drop. But somehow the clinical response to treatment was pretty good. We could not do the imaging post 3 cycles. But apart from that, I don't have a practical experience or a real world experience of using this
Thank you, sir.
particular setup.
Thank you so much, sir.
Dr. Mukesh, if I
Yes,
can
sir.
add, Dr.
Yes.
Chaudhary has a good experience of using it. I think you could speak to him. He says it's got a good response and toxicities are manageable, except for one skin rash. He said had a severe skin rash.
Okay, definitely, sir. Definitely, I will ask from him. So now moving on to the next session. So now I welcome Dr. Vinay Bhatia, Head Molecular Biology and Genomics at OncoQuest Labs, Gurgaon. Sir will be speaking on decoding breast cancer biology, rethinking chemotherapy decisions. Welcome and over to you, sir. Sorry, ma'am. Sorry, I'm so I'm extremely sorry. Yeah, welcome, ma'am. Welcome. You are
Now,
on mute,
please
ma'am.
allow for the slide sharing.
Yeah, you need to unmute, ma'am.
So good evening, everyone. Am I audible?
Yes, ma'am, you are audible, and I'm sorry for
So yeah, no worries. So I'm sharing my screen. Is my screen visible?
Yes, ma'am, it is visible.
So thank you so much, Dr. Bansal, for giving us this opportunity. On behalf of ONCOS Laboratories, I would like to thank to make us the part of this academic feast. So today I would be talking on Mama Print and Blueprint testing modality, which is proprietary testing of Age India, which is a Netherlands-based company. And we are the exclusive partner with Age India for this particular test in test facility in Indian operation. So this is a 150 gene assay which is done on microarray. The test name in combination would have Mama Print as well as Blueprint, which would provide comprehensive treatment consultation as early as initial consultation. So this test would help us in getting the information on the increased precision in chemotherapy treatment response, to identify tumor subtypes for precise treatment planning, and to optimize endocrine treatment duration. So I'll be discussing all these points one by one in my future slides. So before we proceed, we need to know who all are the Mama Print target patients. This test is basically suitable for women with invasive stage 1, 2, and 3 breast cancer. The tumor size should be equals to or less than 5 centimeter in size, should be HER2 negative, regardless of hormone receptor status, which is ER positive or can be ER negative also, lymph node negative or lymph node positive. Up to 3 positive lymph nodes are allowed for this particular testing modality, and tumor content should be at least 30%. Moving on to the common exclusion criteria. So patients which are typically ineligible if they have metastatic disease, or with 4 or more involved lymph nodes, or non-invasive breast cancers like ductal carcinoma in situ, are basically not recommended for this testing. So these are the different trials which had backed these testing modalities. The landmark trials were MINDREC trial, NBREST, SGO3, NS ABP, B42, IMPACT, and the ongoing trials are FLEX, WOG, INSIGHT, I-SPY2, and so on and so forth. So coming to the Mama Print testing, this test was developed on and validated on untreated patients. So altogether, untreated tumor patient sample which were taken up to 20 years of follow-up, and they were categorized into 2 different groups. One is low risk group, the other one was high risk. The basis of this categorization was the patient who were not showing distant metastasis within 5 years were low risk group, while the patient which had shown distant metastasis within 5 years were high risk group. So these two group of patients were put on human genome analysis, and 20,000 genes were analyzed for these patients, and basing on the expression, microarray based expression of these patient of different genes, the different genes were selected. And so eventually this assay is basically developed with genome-wide expression data using an unbiased data-driven approach without a pre-selection of genes. And that's how the 70 genes were identified. And surprisingly, ERPR, HER2, and Ki67 were not among the top 70 genes. So this particular assay, along with Blueprint gene signature, represent almost cover all important hallmark of cancer pathway, and is going to give us guide us, because it is going to give us this genomic signature. It would help us in finding out what the treatment planning can be done basing on these assays. So 70 gene assay Mama Print is basically uh, giving us a stratification of the patient in 4 different categories. One is low and high risk, further subdivided into ultra lower row, and high risk is into high 1 and high 2. And this would help us in planning chemotherapy benefits and de-escalation decisions. The MPI score, which is the testing proprietary algorithm of gene expression profile, is used to calculate the MPI index. And this MPI index would be in the range of 0 to 1 for low risk, and between 0 to -1 it would be high risk. So low risk is further subcategorized into low and ultra low. So low would be 0 to 0.0355, and above 0.035, that is 0.356 to 1, would be ultra low. Similarly, high risk also, high 1 and high 2, between the range of 0 to -0.569 and -0.57 to -1 as high risk 2. So the other assay is blueprint. Blueprint is helping us to do the molecular subtyping. So this goes beyond IAC in fish, which is helping us to evaluate the underlying biology of the tumor. So the blueprint further stratifies ER positive cancer into subtypes with distinct PCR rates. So these are the gene list for a blueprint. So for three different categories are given by a blueprint assay: luminal type signature, HER2 type signature, and basal type signature. HER2 type luminal type signature has 58 genes, while HER2 type signature has 4 genes. Basal type signature would look into 28 genes. So these three different types, luminal type is basically further subdivided into type A and type B depending on the risk group of mama print. If it is mama print low risk, then it would be luminal type A, and if it is high risk, then it would be luminal type B. So similarly, HER2 is also, it is driven by HER2 pathway, while basal type is not driven by ERP or HER2 pathway, and this would help us in selecting patient who may benefit from neoadjuvant treatment. So if we look at the comprehensive reporting format of these two assays, MammaPrint as well as Blueprint, we would have low risk as low plus ultra low, and high risk would have high 1 and high 2, while Blueprint would give us basal type, HER2 type, and luminal type. So when we generate a comprehensive report, then it would be either low risk luminal type A or low risk, ultra low risk luminal type A. If it is high by a MammaPrint, then it would be high risk 1 luminal type B or high risk 2 luminal type B. So similarly, HER2 type would be either low risk or high risk, and basal type is always high risk. So it can be either high risk basal type ER negative or high risk basal type ER positive. So what are the clinical utility of these two assays? So basically, the major clinical utility of this combination of these two assays would be to help us to identify the patient who may safely avoid chemotherapy, who may safely discontinue endocrine therapy before 5 years in the event of ET intolerance, or to find out who may benefit from extended endocrine therapy. So first trial which had backed up this adjuvant chemotherapy decision is MINDEC trial. This trial are almost 6,900 samples were included, and the patient population was clinically high risk but genomically low risk. It means clinical symptom basing on the nodal status or tumor size, it was looking as clinically high, but when we did the MammaPrint assay, it was genomically low. So it was falling under low risk category. So although it was clinically high but genomically low, then when these patients were not given chemotherapy and were put under only endocrine therapy, the distant metastasis-free survival was found to be 95.1% at 5 years of interval. Similarly, the second arm of the study was a patient where CT versus no CT, two arms with CT or no CT were compared, and the 5 years DMFS was almost the same. And when 8 years of follow-up was done, there was a difference of 1.3%. So this was the first randomized prospective data with 8 years of follow-up in lymph node 1 to 3 positive, was published in ASCO 2022. Similarly, the third arm of the study was the patient were categorized based on their age group. So female with less than 50 years of age, when they were given CT versus ACT group treatment. So when ACT versus no ACT was compared, so the 5 years old of distant metastasis-free survival was 96.2 in chemotherapy treatment patient, while when the treatment was not given, it was 93.6. And in case of 8 years also, there was a significant difference. So altogether 5% difference was observed, while postmenopausal female, there was hardly any difference when they compared ACT versus no ACT. So that clearly shows that age is getting some sort of benefit, and the justification can be given that maybe this small chemotherapy benefit most likely due to the secondary ovarian function suppression in case of female under 50 years of age. And the fourth arms for the same study was group of patients which were studied in MINDET trial were 6,693. Out of these 6,693, 1,000 patients were showing ultra low risk by mama print, when this is actually contributing almost 33% of the total population of this study. And when these patients were avoided chemotherapy and were just given endocrine therapy, 8 year of breast cancer specific survival was found to be really good. So it clearly shows that menopausal is ultra low risk in patient distant metastatic free survival. It was almost the same in both group of patient, whether it is menopausal or perimenopausal. So you can look at the percentage given over here. So second added advantage of this assay of mama print is that to give a decision whether endocrine therapy or should be given, or extended endocrine therapy should be given to the patient. So these are the trials which were conducted, the endocrine de-escalation consideration with mama print ultra low risk group. So only ultra risk group patients were taken in the study in this arm, where 98 patients were included, and 97% of breast cancer specific survival was seen in the patient when the treatment was compared, patient group were compared with tamoxifen or with no ET. So their breast cancer survival, specific survival was almost 97%. So this shows that endocrine de-escalation consideration can be done with mamaprint ultra low risk group. So this has been already cited in an NCCN for mamaprint ultra low patient, and this is part of NCCN guidelines. The next advantage clinical utility is to identify who may benefit from extended endocrine therapy. So here the patient, the low risk category, not ultra low risk, were taken in the study, and these are the two trials which were taken, which were conducted, and it has been seen that 10 years of absolute benefit from extended endocrine therapy was seen in case of mamaprint low risk category, not ultra but low risk category. Then there was an increase of median survival rate in case of both lymph node negative and lymph node positive cases. Both the studies has the similar kind of output. So this shows that together the prospective randomized trials demonstrate level 1B evidence that patient with mamaprint low risk benefit from extended endocrine therapy. Now coming to the genomically high risk group, since we were till now we were talking about low risk and ultra low risk category. Now we are talking on high risk ER positive patient. So now with the help of this information, we can identify the patient who can achieve PCR2 neoadjuvant chemotherapy, who may have a TNBC like cancer, patient who may benefit from chemotherapy, and the patient who may benefit from anthracycline. So NBREST trial was done where the pre-operative core biopsy patient sample were taken, around 1,000 sample were taken, and these patients were categorized by IAC and FISH, and of course by this blueprint assay also, and there was 22% discordant in the results. So two major groups were where discordance were observed. So HER2 positive cancer by ISC or FISH were actually basal type by blueprint. Similarly, ER positive cancer by ISC were genomically basal by blueprint assay. So there is a discordance result. So that had led to some sort of information. So ISC categorized patient were showing PCR of 10%, but when the patient were categorized by blueprint into different group like luminal A, luminal B, HER2 type or basal type, we had discussed in the introductory slides. So it has been seen that 28% of ER positive mamaprint patient high are actually basal type. So that was a part of NBREST trial also, and I-SPY study also. So 5 years outcome in NBREST trial was pre-operative mamaprint and blueprint breast cancer subtype is associated with...
Dr. Vinay ma'am, sorry to interrupt, but you have only a couple of minutes to, in
Sure,
1 or 2
sure.
minutes, if you can just
Yeah,
conclude
sure.
with the final discussion.
Yeah. So this information is associated with neoadjuvant treatment response and survival. So this is the recent addition in NCCN that patient with mamaprint high 2 category with both luminal B and luminal basal type were recommended were showing good response to anthracycline-based neoadjuvant chemotherapy. This is the gist of this slide. And this is the latest addition in NCCN guidelines. We can clearly read over here that non-randomized data suggests the patient with mama print high 2, MPH2 tumors have significantly worse outcome when treated with taxane-based regime without anthracycline. So when can we incorporate anthracycline in the treatment? That can be based on this genomic profiling where blueprint and mama print both are processed. So this is a report format where we do get all the information, whether patient is low risk, ultra low risk, and what is the score of MPI, what is the blueprint score, and basic on neoadjuvant chemotherapy, adjuvant chemotherapy planning, or adjuvant endocrine chemotherapy planning, along with extended endocrine treatment planning is being given in the report. And this is the laboratory version of the report format. And these are the trials which we have discussed. So all these 13 trials which were conducted have been marked in the report format itself. And this is a small comparison of different testing modalities available. Oncotype DX is which is very commonly used. So we can compare this assay as more or less it is same, but Oncotype gives us intermediate score also, where there's no, it is a binary, either high risk or low risk. Prognostic predictive value both are there in both the assays, but predictive value as compared to regime, which is anthracycline, is only and only included in mama print. There is no gray zone like in case of Oncotype. So either it is clearly either it is positive, high risk or low risk. Thank you so much for your patient hearing. I would be happy to answer question if I have.
Thank you so much, ma'am, for the excellent detailed discussion you have. It was such an insightful discussion. We gained a lot of things from this. Just wanted to know, as you have shown also, there is some discordance between the ER positivity and the MemmaPrint high and low score.
Yeah.
So can we expect in future that especially the gray zone areas like low ER positive, ER 1 to 10%, we can
Right.
use MemmaPrint type technology and then decide whether to treat it as a TNBC or a hormone positive
Yeah,
tumor?
so looking at the sensitivity and specificity of this assay and looking at the trial result which we have seen, it is clearly shown that there's a 22% discordant in ISC fish versus this assay. And future is this genomic profiling in spite of the traditional method. So that is definitely going to help in global level. People are moving to these global subtyping. Of course, will take some time, but yeah, people are adapting to these.
And another point, ma'am, I think you said that we can stop the drug, hormone drug at 5 years if it is showing
Yeah,
low
yeah.
risk. So I think it is unique to the MemmaPrint only. I think with
Absolutely, absolutely.
Oncotype or
No
NSSP
other
type.
assay does give us this information. Only chemotherapy can be given or not. That information we are getting here. We are getting information on endocrine treatment planning as well as extended endocrine treatment planning, both.
Thank you, ma'am. Thank you so much, ma'am. Thank you.
Most welcome.
Sir, you are saying anything? Dr.
No,
Cooper,
no.
sir? You are on mute, sir. I think you want to say something. You are on mute, sir. Yes. You are
Sandeep
not
sir, we are not able to hear you.
You are not audible, sir.
Yeah. So Mukesh sir, can we have the final conclusions from your side and then we say thank you to everyone?
Yes, definitely. So, with this, we come to the conclusion of the day 2 also, and the total academic event also. First, thank you, Dr. H.P. Singh, sir, for chairing the sessions and actively participating in the sessions. And thank you to the Cancer Research and Statistic Foundation. Thank you, all the speakers, moderators, panelists, delegates, students. Thank you, all our pharma partners, our sponsors, who are academic partners who have actively participated. And thank you, the entire team of the Horizon, Mathurji, Manya, Daud, and everyone. And thank you, everyone, for making it a very successful event. We hope to come. We will meet next year with the 4th edition of the ONCOV, hopefully.
Thank you, Dr. Mukesh. I think it was a wonderful conference, and we look forward to your next year again.
Thank you, sir. Thank you.
So thank you so much, and once again, a very warm good evening to everyone. As with the permission of Dr. Mukesh and on behalf of my team, Daud and Manya, we say thank you, good night, stay safe, stay blessed, and we meet next year again. So thank you so much, and tech team,